Okay, this is chapter 80. We're going to be talking about the sensory system um disorders. Let me call it. I done stretched it out too much. Hold on. I close this in. Oh Lord. Here we go. Y'all bear with me. Why is this stuff? Oh, there we go. All right, so boom. So right here, I need to make it a little bit so we can see it. There we go. So this is just the introduction. The sensory system, it involves those organs and structures that give individuals information about the surrounding world through the senses of the sight, hearing, touch, taste, and smell. We know about what senses are. So the receptors for these senses are located in the peripheral part of the body. The nervous system, what it does is it's going to transmit the impulses that's sent from the sensory system to the brain for interpretation. So whatever you touch, it got to go up the impulses. It's going to be transmitted to the brain and say, okay, I touched something hot, I touched something cold, and then your brain is going to say whether determine whether it's hot or cold, not the touch, but your brain. And that goes for all the rest of this other stuff. Any defect in the sensory organs or the brain itself or in the transmission of nerve impulses to the brain can cause a malfunction. Now let's talk about these diagnostic tests. The eye and vision test, the visual acuity. So this examination or the examination for the visual acuity, we all done had it before. It's a Snellen chart. It's all those big and small letters. When they say cover one eye, cover the other eye. So that's what the Snellen chart is. And it's going to determine the person's ability to see at specific distances. This chart has a series of a progressive smaller rows of letters. So they're going to start off small, then they go big. So they start off with the small letters, then they go to the big letters. So the person is usually positioned 20 feet from the chart and is asked to identify the letters on a specific line. The term 20/20 vision means your ass can see. This is normal vision, but I should have highlighted that. That means this is normal vision. But here we go. Okay. And the person with 20/80 vision, they can see at a distance of 20 feet what a person with 20/20 could see at 80 feet. Okay. And then the US definition, which is the United States definition of blindness, is visual acuity equal to or worse than 2200. Visual acuity equal to or worse than 20 to 200, or a visual field of 20 degrees or less in the better eye. That's the US definition of blindness. Is a visual acuity equal to or worse than 20 to 200, or a visual field of 20 degrees or less in the better eye. Refractive examination. So with the refractive examination, it is used to identify the degrees of refractor errors and determine the types of necessary, well, the types of lens necessary to correct a visual defective. So that's the refractive examination. It's there to identify the degree of refractive error and determine the type of lens necessary to correct a visual defect. The pupils, they may or they may not be dilated, open for the examination, okay? That's dilated. They may or may not be open during the refractive examination. Drops such as cyclopentolate, phenylephrine, um, scopolamine, hydrobromide, tropicamide, or used to dilate the pupils. I have to go slow with those words. I probably fucked some up, but y'all can read them yourself. So these drugs, they are used to dilate the pupils. So you can kind of sort of remember that, but this isn't, pharmacology, this med surg, so I probably wouldn't even try to remember that. So dilated pupils provide the examiner with a view of the interior structures of the eyes and paralyzed accommodation ability to focus at various distances. That's going to be in younger clients, okay? So dilated pupils, what they're going to do is provide the examiner with a view of the interior, that's the inside structure of the eyes, and paralyzed accommodation in younger clients. This allows for more accurate testing for glasses. A phoropter is an instrument that stimulates different corrective lenses. It's placed in front of the client's eyes. We've all had this when we're trying to see which lens is the clearest for us, so we can get glasses. You know, that's if you had to have glasses. Whoever had to have glasses had a phoropter in front of their eyes. So, phoropter is an instrument that stimulates different corrective lenses. There's going to be different lenses that are placed in front of the client's eyes, trying to find out which one gives the clearest vision. Whichever one gives the clearest vision, that's the one that's the one that's good for the eyes. So that client is going to get that set of lenses so they can get some glasses. So basically, lights from the examiner's retinoscope is streaked across the eye, while the lenses from the phoropter are adjusted until the light streak is neutralized. The final corrective lenses are selected by alternating similar lenses and having the client indicate which lens provides the clearest vision, like I said. So, if I was y'all, I'll highlight that. So, the ophthalmoscope examination. The ophthalmoscope is an instrument used by the examiner to look through the pupil to see the retina and other interior structures. The examination provides information about the blood vessels of the inner eye, especially those of the retina, as well as info about the presence of tumors and the conditions of optic nerve. So that's the whole reason we do an ophthalmoscopic examination. We're going to use the doctor is going to use an ophthalmoscope, which is an instrument. He's going to be looking at the pupil to see the retina and other interior surfaces. He's going to even be looking at the optic nerves to try to see if there's any type of tumors or if there's any type of swelling of the optic nerve, you know, things of that nature. So the examination provides information about the blood vessels of the inner eye, especially those of the retina, as well as information about the presence of tumors and the conditions of optic nerve. So the blood vessels of the eyes, they suggest the general condition of blood vessels throughout the rest of the body. So atherosclerotic and hypertensive changes in blood vessels of the eye are usually a sign that the same condition exists elsewhere. So with me, I have intraocular hypertension because I have high blood pressure. So y'all been seeing me for these almost 20 months now with red ass eyes. So I've been fighting and I've been dealing with that, trying to get my blood pressure under control. But this is the reason why I don't have glaucoma. I have hypertensive changes, hypertensive issues. That's why my eyes are red. So basically, the blood vessels of the eyes, they suggest the general condition of blood vessels throughout the rest of the body. So the eyes, pretty much my eyes, you know, and like I said, atherosclerotic and hypertensive changes in the blood vessels of the eyes are usually a sign that the same condition exists elsewhere. Okay. So slit lamp examination, with the slit lamp examination, it's a special type of microscope that directs a beam of light onto or through the cornea to view the eye's anterior surface. That's what the slit lamp does. It's a special type of microscope that directs a beam of light onto or through the cornea to view the eye's anterior surface. The magnification of the images enables the examiner to identify abnormalities of the conjunctivae, cornea, anterior chamber, iris lens, and anterior virtue. The slit lamp also may be used in association with a type of magnifying lens to view the eye's posterior surface, which is posterior structure, which is the back of the eye. Tonometry. I've had this a lot of times. This is trying to measure the pressure of the eye, intraocular pressure of the eye. That's what tonometry is. It's two devices. You got this device is Schiozzi. I don't know how to pronounce it. Schiozzi tonometer and the more accurate applanation tonometer. And these are used to measure the pressure in the eye and detect glaucoma. Other tests are the retinal angiogram. It's a visual depiction of the blood vessels. When you see angio, you know they're talking about vessels. So angiogram, the retinal angiogram is a visual depiction of the blood vessels in the retina following the injections of radio packed dye. And anytime you really see a word like this together, you know it's going to be some radio packed dye. So make sure you check to see if this client have any type of issues as far as if they're allergic to shellfish. Ocular ultrasounds, they may be used, right? And the ERG, which is the electroretinogram, records the minutes, electrical impulses. That's the key word, electrical impulses given off by the retina when it is struck by light in much the same way as electroencephalogram, EEG, is recorded. And that's about the brain. So the ERG, which is the electroretinogram, determines whether the retina is functioning. So it's just basically electrical impulses. It lets you know whether the retina is dead or alive. Local anesthesia is used for this test. A contact lens containing the electrode measuring device is placed on the eye. The client head is under a cone, and much of the test is done while the room is dark. The ERG can confirm a diagnosis of retinitis pigmentosa before the condition can be determined by other means. Okay, so that was all the diagnostic test for the eye, the eye, for the for the eye and vision test. Then we have the hearing test. Okay, so now we are at hearing, the ear and hearing test. So with the otoscopic examination, the otoscope, that is going to be the fundamental piece of equipment used to examine the ear. So, you know, when you go to the doctor's office and they put that little otoscope with the light on it in your ear, because it has a light and it has the magnifying glass, and they're looking up in there to see like what the hell going on. So magnifying lens. So it's the light, the magnifying lens of the otoscope. Healthcare provider examines the external ear, tympanic membrane, and the anatomical points beyond the eardrum. You know, they put a disposable piece on there. They're not using the same little thing and hitting it with a baby wipe and putting it in your ear. They put that little disposable piece on there, throw it in the trash. Several sizes for adults, children available. Nurse commonly assists the practitioner with the eye and ear examination by providing the appropriate equipment, checking to see that the light is working, and helping the client to remain still during the examination. So they can also use the otoscope to, you know, shine that light in your eye to see if your eye is doing the perla. Pupil equal round and reactive to light, and that A stands for accommodation. And usually for accommodation, I mean, we do it as nurses, but mainly that's something that a neurologist would really focus on. So audiometry, with the audiometry, it's a test of hearing. That's why you got audio, and metry will be measuring. So it's a test of hearing. So pure tone audiometry test, both conductive and sensory neural, sensor, sensory neural hearing deficits. Okay, it's going to be the pure tone audiometry test, both. This pure tone audiometry is going to test both the conductive and sensory neural hearing deficit. And the bone conduction audiometry, what it's going to test is just conduction loss. So bone conduction, conduction loss. Bone conduction audiometry, conduction loss. Pure tone audiometry, It's both the conductive and sensory hearing deficit. So with the caloric test or caloric test, caloric study, this is a test designed to determine if an alteration exists in the vestibular origin of the acoustic nerve. So you got the abnormal test. What that means is it suggests that there's going to be a disease of the labyrinth or a tumor of the acoustic nerve. This test can differentiate such disorders from disorders of the brain stem. Okay, so that's what the caloric test does. The caloric test is designed to determine if an alteration exists in the vestibular origin of the acoustic nerves. Abnormal test results, such a disease, labyrinth, or a tumor of the acoustic nerve. This test can differentiate such disorders from disorders of the brainstem. Now, the procedure, the client is either going to be seated or laying down. Laying down is the supine position, laying down on the back. And water is going to be instilled into the external ear. Remember, the water is going to be either cold or it's going to be warm. It's going to be alternated. But I want you to know this: you will never pour water in someone's eardrums who is punctured. So anybody having some have a punctured eardrum, you're never going to pour the water in there, and we'll talk about that in a few. So the affected side is tested first. We're gonna test the affected side first, because the reason we do this, because less of the reaction is expected to occur there. Less of a reaction is expected to occur there. That's why we test the affected side first, because there's going to be less of a reaction is expected to occur there. The normal response to the test is nystagmus, meaning they got that rapid rhythmic eye movement. They may have some nausea, vomiting, vertigo, that spinning sensation, and a feeling of falling. Decrease or absence of these responses within 3 minutes, some ain't right. That's going to indicate an abnormality. So if there's decrease or if there is absence of the nystagmus, um, or the nausea, the vomiting, the vertigo, or falling, something going on with that person. That's abnormal. Contraindication, I already told you, don't put no damn water in nobody's ear who is punctured. So you're not going to be able to do that procedure on them. So instead, we're going to use cold air. Cold air may be substituted for somebody that got a punctured ear, and we got to do that procedure on them. So the client who is having an attack of Meniere's disease, um, let me tell y'all what Meniere's disease is. It ain't nothing but it's just vertigo. Client may not even be able to hear. It messes with their hearing. And a person who just got diagnosed with Meniere's disease is the singer Tank. The singer Tank. He has been diagnosed with Meniere's disease actually this year. So he said he's going deaf. So I don't know. So the client who is having an attack of Meniere's disease should not be tested until the symptoms of Meniere abate, meaning until the Meniere is gone, until it stops, until it's over with. So sedatives and anti-vertigo agents may interfere with test results. So you need to ask your patient, or ask your patient before you come in and do this test. I don't know. We're gonna keep going on to see how many hours, or that they should not take it. They shouldn't take a sedative or anti-vertigo uh, med. So we got to find out. So because sedatives and vertigo, I'm talking about vertigo, anti-vertigo agents, they're gonna fuck with the test. So don't put water in the ear. We're gonna use cold air instead. If they got a Meniere attack going on, well, attack of the Meniere disease, don't do it. You can't test them until the shit is gone. And then sedative and vertigo medicines or agents, they're gonna fuck up the test. They're gonna interfere with the test. So you're not going to do those as well. So moving on, concept mastery. No, not nursing consideration. Because nausea and vomiting are likely keep the client nothing by mouth or on liquid before the test and provide an emesis basket. The client is usually returned to the room by a wheelchair. They're going to be allowed to lie down until the nausea subsides, which is usually no more than an hour. Concept mastery alert with the caloric test. Let's talk about that again for the concept mastery alert. When performing a caloric test or study, the affected side is tested first. Testing the unaffected side first may cause nystagmus, vertigo, nausea, and vomiting. The reaction would make it more difficult to assess the reaction from the affected side, which will have a decreased amount of these findings. Okay? So when performing a caloric test or study, the affected side is going to be tested first. The affected side is tested first. Testing the unaffected side first may cause nystagmus, vertigo, and nausea and vomiting. And these reactions will make it more difficult to assess the reaction from the affected side, which will have a decreased amount of these findings. Now let's talk about the electronystagmography, which is the ENG. These are electrodes. Anytime you get to see an electrode, you know, there's some electricity and electrodes taking place. So electrodes are placed near the client's eyes to assess for alteration in the vestibular system. In the ENG test, in the ENG, the caloric test is performed while eye movements are recorded on a graph. Other test components are the same as the caloric test. Okay? So they're going to hook up that electrode near your eyes to assess for the alterations of vestibular system in the ENG. The caloric test is performed while eye movements are going to be recorded. Other test components are the same as for the caloric test. Other tests, MRIs, what it does is it's going to be used to detect tumors, the MRI, detect tumors of the eighth cranial nerve. What's the eighth cranial nerve, you guys? Look this shit up because I don't have the paper in front of me. Um, what's the eighth cranial nerve? I ain't finna look it up. Y'all look it up. In EEG, and just write the eighth cranial nerve. You can write it. If I were you, I'll write it right here. With the EEG, with the evoked responses, it can be used to detect abnormalities of the nerve pathways between the eighth cranial nerve and the brain stem. That's what the EEG is going to be used for. With evoked responses can be used to detect abnormalities of the nerve pathways between the eighth cranial nerve and the brain stem. Another test of the function of the vestibular system and the semicircular canals involves seating that client in a chair that's going to revolve in several planes, like this, just revolving in several different planes, and then evaluate the functioning of the client's sense of proprioception, meaning the location in space, and vestibular system. Here are some common medical treatment. We may give a client an eye patch. So, in eye patching, in some cases, healthcare provider orders one or both eyes to be patched. A simple single patch or double patch may be used to cover the rest, where the eye for the rest of the for rest of protection, for rest or protection. Okay, a pressure patch is taped in place, may be used to keep the eye closed. That pressure patch is going to be taped in place, and we may use it to keep the eye closed. Put a little pressure on there so we keep that eye closed. Pressure. Trying to keep something closed. We're going to put a little pressure on there. Metal shield over the patch. Well, think of why, someone would use a metal shield. Protection. It's protection. So I look at the metal shield like it is a bulletproof vest or something. We use that metal shield to protect the eye. Pressure patch. We're trying to keep something closed, so we got to put pressure on it. Simple single patch or double patch may be used to cover the eye for the rest, or protection. Nursing alert. If one eye is patched, the Client will have a depth of perception and peripheral vision. The client should not be in no motherfucking car driving nowhere or perform duties that could be deemed as unsafe to the individual or others. So that's operating heavy machinery. So if both eyes are patched, um, this client is going to be apprehensive and they're going to have some confusion and disorientation when one or both eyes are patched. Cotton tip applicator. A cotton tip applicator or dry wipe. Cotton tip applicator, aka a dry wipe, may be ordered to clean drainage out of the external auditory canal and the auricle. So now we're talking about the ears. So with ear irrigation, may be performed to rinse, drain, or medication from the ears and to remove wax or foreign bodies. So think about when you do that irrigation on I think it was with the turp, after the client gets the turp, and then we irrigate the male's, um, what is it, like the prostate, or we put the catheter in there and we irrigate it to suck out the blood clots and stuff to make sure there's no blockage so they can uh, pee pee. So this is the same thing with the ear. We do it. It may be performed to rinse drainage or medications from the ear and to remove wax or foreign bodies, making sure nothing is building up and blocking nothing in there and possibly causing an infection. It is only, it is done only with the healthcare provider's order. You can't just go in there and talk about you finna irrigate somebody's damn ear and you don't have an order. Got to have an order. Okay? Do not irrigate the ear if the client's eardrum is punctured. Irrigating the ear or instilling meds require different techniques for the adults and the children. This is what we got here. So, technique for irrigation of external auditory canal or installation of eardrops. Note the difference in direction of pull on the pinna between. The adult, remember this shit might be on the test. Hold on. This is the kind of stuff they will put on the test on our ass. This pink. Is that pink? Yeah, that's pink. Adult, up and back. Child, down and back. What happened? The child is down and back. What the hell is this all about? Okay, so we got that. Adult, up and back. Children look up to adults and because they're tall. So up and back. Child look up to the adult. The parent look down at the child. Down and back. So children are down. Down and back. Client patients are, adults are up and back. Child down and back. I know that's going to be on the test. Common surgical treatments, eye surgeries. So with the eye surgeries, most surgical procedures on the eye are performed as same day surgery. So you get that bitch and you go home for the day. You get that procedure, take your ass home. In many cases, clients receive local anesthesia. They may be awake during such procedure. Eye surgeries involve precision. Everything has to be precise. So it's precision, meaning everything has to be done right. Often they are done with the aid of an operating microscope. The client's cooperation is essential. Therefore, preoperative clients and family teaching is important. The following actions are review activities permitted before surgery and restrictions following the procedure. We want to teach clients and families how to administer eye drops or other meds prescribed to dilate the eye or treat um, infections. Review other procedures such as eye patching. Outline the steps of the surgery what will be done and what is expected of the client. Tell the client if he or she will be awake during the procedure. Review post operative care before surgery. Remind the family that someone will need to drive the client's home after surgery and probably to help him or her for at least a day or two post operatively. And you can find that at, well, you can also find some information in in practice, educating the client, box 80-1. This is the box. I just typed it up. So, educating the client after eye surgery. Do not remove your dressing, leave the drain in place because you might fuck around and break the center line. So, we do not do that. The doctor removes the dressing. Do not use meds until you see the surgeon, usually on the first post operative day. Bring your eye medication to that appointment. If a metal shield is prescribed, wear it while sleeping or napping for up to 4 weeks to protect from being accidentally bumped or touched. If both eyes are patched, if both eyes are patched, you better be sure to ask your family for assistance. Make sure they know how to help you. Do not sleep on the operative side. You have to sleep on the opposite side, which is the side that was not operated on. And you need to do that for at least a week to prevent the fluid and pressure from accumulating on the suture line. After the first post-operative day, clean the eye gently to remove mucus. Use cotton balls or tissue moistened with tap water. Follow these actions to avoid disrupting the center line. You're going to avoid sudden movement. Do not press on or rub the operative eye. Avoid bending over with the head below the waist for about 2 weeks. Avoid straining at stool. Avoid vomiting. Use antiemetic if prescribed. Avoid activities such as coughing, sneezing, nose blowing, and vomiting. Do not lift more than 10 to 20 pounds for about a week. Try not to bump or shake the head vigariously. So, my mama had a friend, and she died this year. Well, her homegirl sister died this year. Uh, had eye surgery, went to lift up on her grandbaby the same day or the next day, and she died. She ended up dying. That's why they tell you don't lift up on shit. So don't go home and try to lift up on no big ass baby. Okay? I don't give a damn if they're 35, 40 pounds. That is too much straining on the center line. So shampoo with the head back for at least a week. Avoid falls and jolts. Be careful walking on ice or up and down stairs. Depth perception may be altered postoperatively. Avoid getting soap in the operative eye. Bathing and showering are permitted. Read, watch TV, and may ride in or drive a car as vision permits. Follow the surgeon instructions about your stitches, which may need to be removed or may be absorbable. Know that glasses will probably be fitted in about 6 weeks. They may need to be changed during the first year as the eyes adjust. Report any excess drainage, sudden pain, or bleeding to the surgeon ASAP. Enucleation. Enucleation is the removal of the eye. Enucleation. They put a nuclear bomb in your damn eye and blew that bitch out. So that's how I can remember enucleation. Enucleation. If I'm even saying that shit right. Enucleation. Yeah, I'm saying that shit right. Because it sounds like nucleus, nation. So nucleation is removal of the eyeball. They put a nuclear bomb in your eye and blew that bitch out. So this procedure may be done when disease or injury has destroyed the eye or if a malignant tumor develops. After that eye is removed, a metal or plastic implant is going to be buried in the eye in the empty eye socket, right? So what's going to happen is the eye muscle attaches to the capsule and it moves that implant. And after healing, it complete a glass or plastic prosthesis shaped like a shell is fitted over the berry implant for cosmetic purposes. So the shell is going to be painted to match the other eye. And then the care for the prosthetic eye, the client must learn how to insert and remove the prosthetic eye and how to care for it. Some type of prostheses are removed at night and placed in a solution. When practicing insertion and removal, the person they gotta lean over. That's important to know. They need to lean over a soft or padded surface to prevent the eye from just slipping the fuck out and breaking. So they're trying to prevent possible breakage of the prosthesis because it's a glass eye. The current version, though, they're kind of made of plastic, so it's kind of hard for them to be broken. Now, if the nurse is required to insert a prosthetic eye, do the following: wear gloves, wear gloves, and wet the prosthesis. And the rationale is this action allows it to just slip the hell in easily, lift the upper eyelid, and you're going to slip the eye up under the top lid. Hold the prosthesis while pulling down gently on the lower lid. Slip the lid over the edges of the prosthesis. Ask the client to blink. Blinking should pop that bitch in place. It's going to be seated in place. To remove the prosthesis, pull on the lower lid. Now you got to press inward on the bottom of the prosthesis, which should cause it to slip out. And then you need to be sure to work over a soft surface, again, like I said, when you were putting it in, or to avoid breaking the prosthesis. When caring for the eye socket, follow the healthcare providers. Rinse it with tap water or a mild solution available for this purpose is recommended. Okay, we're going to be talking about providing eye care in surgery. Okay, so y'all, I forgot where I stopped at on this page, but let's pick up. I forgot where I stopped at, but anyway, providing. Let's start with providing in eye care surgery. So the providing care in eye surgery, you want the clients and the family teaching. You need to do that. That's essential, especially for the clients who are older or who are confused. Make sure to cover and to document all teaching. We already know that kind of stuff. Now, when preparing the client for eye surgery, also include the following. You're going to make sure to perform all items on the preoperative checklist, and the client must sign an informed consent before any preoperative medications are given. We know that kind of stuff before surgery. Check to ensure that the client was NPO after midnight. I think I read all this, but I'm gonna do it again. If an early procedure is scheduled, also note whether the client has taken a laxative or received an enema the night before surgery. If prescribed, you want to assist the client if he or she is confused or has a sedative. Wash the client's face with surgical soap as ordered. Wash it with surgical soap. Do not go and get no Family Dollar soap. Wash it with the cervical soap. It's ordered. If necessary, ask the male client to shave immediately before surgery. You're going to instill the eye drops if ordered. If the client eyelashes are to be clipped, use a blunt scissors coated with petroleum. Rationale: the petroleum catches the eyelash and it prevents it from falling into the eye. So remember, I think you should remember, especially those three things. That could be some select all that applies, maybe, maybe not. Report any signs, because this is what we're doing as a nurse. So report, that's why I say select all that apply. So report any signs of respiration, infection, and the rationale behind that is because they ass ain't gonna have surgery if they got something going on with their respiratory issues. If the client I'm sorry, if the healthcare provider has ordered the client's eyes to be patched preoperatively, find out what type of patch. Do they need a single patch? Do they need the metal patch? Or both eyes going to be patched? You need to find that out. And let the client know as well. So explain the reason for patching to the client so you can reduce apprehension and confusion. That's the rationale behind it. Have the client bring a hearing aid to wear during the surgery. Rationale: the client must be able to hear the surgeon's instructions. Okay? So you want to perform and document our preoperative teaching, answer any questions the client or family may have. Now, after the surgery, post-operative care, this is what we're going to do. Because that client, they usually go home right after the surgery, the post-operative care is going to center around the clients and family teaching because they're going home. So they're going to be the ones caring for themselves, or the family is going to be helping out after surgery. Let they ass know. Do not take your ass home coughing and sneezing and lifting up on shit over 10 to 20 pounds, and shaking your damn head to your favorite goddamn Lil Boosie fucking song. Don't go home doing none of that. So don't shake your head, no sudden head movements, okay? No head bang around this bitch. Because what will happen, these actions can cause sudden fluctuation in intraocular pressure that disrupts the southern line, okay? So focus clients teaching on preventing complications such as hemorrhage, increased intraocular pressure, stress on the suture line, and infections, okay? And then you can find that in 80-1. Did I put that in there? Shit, what is it? Let me look at my book. Let me look at my book. 80-1. What that is? Educating. Is that educating? Educating the client. If I don't see it in here, I'm definitely gonna add it in here. Let me see. Oh, educating the client after eye surgery. Damn, they say ear surgery. Okay, I didn't. hmm, I'm surprised. I didn't put that shit in here. It'll be in here for y'all. But if you go to page in the new book, 1404, let's read it together. So 1404, do not, I repeat. Okay, so 1404, the one we're reading is in practice educating the client, 80-1 after eye surgery. Okay, it says, do not remove your dressing. Leave dressing in place. Do not use medications until you use until you see the surgeon. Bring your eye meds to that appointment. If a metal shield is prescribed, wear it while sleeping or napping. You got to do that shit for up to like 4 weeks. We're trying to prevent accidentally bumping or touching the eye. If both eyes are patched, be sure to ask your family for assistance. Make sure they know how to help you. Do not sleep on the operative side for at least a week to prevent fluid and pressure from accumulating on the center line. So let's say they end up having surgery on both sides. They need to sleep on them in the supine position, or just sit your ass up in a recliner and go to sleep. But do not sleep on your left nor your right side or the affected side. After the first post-operative day, clean the eye gently to remove mucus. Use cotton balls or tissues moistened with tap water. Follow these actions to avoid disrupting the center line. So we're going to avoid sudden movement. Like I already said, do not press on or rub the operative eye. Avoid bending over with the head below the waist for about 2 weeks. Avoid straining at stool. Avoid vomiting. Use antiemetics if prescribed. Avoid activities such as coughing, sneezing, nose blowing, and vomiting. Do not lift more than 10 to 20 pounds for about a week. Try not to bump or shake the head vigorously. Shampoo with the head back for at least a week. Avoid falls and jolts. Be careful walking on ice or up and down stairs because depth perception may be altered postoperatively. Avoid getting soap in the operative eye. Bathing and showering are permitted. Read, watch TV, and may ride in or drive a car as vision permits. Follow the surgeon instruction about your stitches, which may need to be removed or may be absorbable. Know that glasses will probably be fitted in about 6 weeks. The way where they may need to be changed during the first year as the eyes adjust. Report any excess drainage, sudden pain, or bleeding to the surgeon, AS motherfucking AP. Okay? So, nursing alert. Report any paralysis of the face or on the operative side or ptosis, which is drooping eyelid, and immediately, okay, do that shit immediately. Report any paralysis of the face or on the perioperative side, I mean, on the operative side, orthosis, which is drooping eyelid, ASAP. Rationale, these findings may indicate damage to the facial nerve or the presence of edema. Okay. So with ear surgeries, because many ear surgeries are done on an outpatient basis, nursing care centers around client and family teaching. If that client is in an acute facility, the same principles apply, okay? It doesn't matter. Cochlear implants, the cochlear implant, that's what the doctor said when I went to go get my damn ears checked. They said, baby, you can't hear shit and you can't even get these. So, but what a cochlear implant is, this is a surgically implanted device that emits an auditory signal, bypassing a damaged cochlear system and stimulating the remaining auditory nerve tissue. So it's basically help you hear. That's all ocular. I'm talking about ocular, cochlear implant do. So with the procedure, it is for the profoundly deaf or severely hard of hearing person and allow sound perception. That's me. That's me, severely hard of hearing. And they said I don't qualify for it. Just, oh, whatever. So there are several classifications of implants, location and transmission of the auditory signal, and the types of implanted electrodes and stimulation of nerve tissue determines the type and classifications of implants, right? So, location and transmission of the auditory signals and the type of implanted electrodes and stimulation of nerve tissues determine the type and classification of implants. A cochlear implant has an internal coil with a stranded electrode lead that is surgically inserted into the cochlea. The um, the external coil or transmitters align with the internal core or receiver by a magnet. I'll probably send out a video. I'm gonna try to watch a video on this because this is telling us what the hell it does. So when the microphone receives sounds, the stimulator wires receives the signal after it's filtered. So I believe with this, like the stimulator wires and with their cochlear implants, it's like when the cochlear implant picks up on noise, those stimulator wires, they are in place of the little it's the little bones in your ear, the little fibers. When you also have um hairs in your ear, and they help you pick up on signals. I know this because listen to me, goddamn it, I'm the one going through ear issues. So I've done research on this. So anyway, so once those little fibers start vibrating and pick up on the noise, you know, it's gonna go. That's how you hear. That's how you hear sound. That's how That's how you receive the sound. It's from those basically stimulator wires. They receive the signals after it's been filtered. So this filtering allows the sound. See, I already told you. It allows the sound to transmit comfortably for the client. Sound is then passed by the external transmitters to the inner coil receiver by magnetic conduction and is finally carried by the electrodes to the cochlea. But in a real ear, like without this cochlear implant stuff, it's like nerve, like hair fibers. They help you hear. And then you got those little bitty small bones like the stapes and meniscus, whatever the damn. The stapes is the smallest bone in the body, and it's in your ear. So those are also what help you hear. So the potential candidate for a cochlear implant, which is not my black ass, must be an otherwise healthy individual with no evidence of mental retardation or psychological disorders. I don't have none of this shit, but they won't let me get it because they said the shit ain't gonna help me. So the client must be unable to recognize words spoken away from the line of vision and be realistic and optimistic about the results. Because with a cochlear implant, y'all look that shit up because it's some good things, it's some bad things. That's why you encourage your patient to talk to others before they have this surgery because I've heard a lot of negative things about the cochlear implant, and I've heard to the point people want to commit suicide after getting a cochlear implant because of a vibrating or ringing type noise that fucks with them so bad. It's like it's nerve wracking. So just find the video on that. That's important to know. Well, if it y'all ass can hear, y'all probably don't give a damn, but I'm gonna watch a video on it. So post operatively, treat the client similarly to others who undergo middle ear surgery. Within a few weeks after the surgery, the controls on the implant are adjusted and the rehab process begins. Client must learn to discriminate between sounds and voices. Listening will take patience and training. So providing care in ear surgery, preoperative care. So what y'all need to know about this, we already talked about. It's like the same shit. But for any surgery, what are we going to do as nurses when these patients come through the door and they have to have these type of surgeries? So um we are going to prepare them for what will occur and what to expect before and after the surgery. The client often is awake for surgery and must be able to follow instructions. Be sure to let the client know this preoperatively. Eardrops may be instilled or the client's ear may require packing with cotton is ordered, okay? So just know all of this. Post-operative care, what the fuck we gonna do, you know, if the client is gonna go home? Immediately after surgery, we want to teach the client and the family how to perform care. Now we did that shit in the preoperative care, but we're going to remind them again in postoperative care, but we're not going to get them too much. This just to be like a follow-up and like a reminder. Usually the client is allowed out of bed as soon as he or she leaves the recovery room. Someone must be available to drive them home. No, they can't drive home by themselves. If the nurses to change dressing or instill meds, be sure to follow strict accepted technique. Let me tell you why. Because the ears, they're close to the brain. You don't want to get that client meningitis or encephalitis. That's why you want to make sure you maintain a strict accepted technique and you wear gloves because the ears are close to the brain. That's the whole reason why. Oh, and instruct the client not to remove the dressing. That's the doctor job. We already know that. So in practice, educating the client 80-2 after ear surgery. Okay, since I put this one up there, I'm gonna go on and read it. I cannot believe I didn't put that up. Yeah, I didn't put that other one. The 80-1 eye surgery. I didn't put it, but y'all know what page it's on. I'm gonna add it in here. It's just not gonna be on the video. So keep any dressing and packs in place for several days or as directed by your surgeon to avoid disruption of the delicate suture line and to prevent infections. Watch for signs of dizziness or prolonged nausea. These are symptoms of inner ear disturbances. Avoid vomiting because it can disrupt the delicate suture line. Take antiemetics as ordered. Okay, so you won't have to worry about, um, possibly busting that damn sutter line open because your ass sick, well, or vomiting. Avoid abruptly changes in position. Do not sit up quickly. Take your damn time, Speedy Gonzalez. Do not be in a hurry. These actions may overstimulate or upset the semicircular canal of the inner ear. Okay? You want to avoid sudden movement, straining, lifting, or acts such as sneezing or coughing. Just like I said, don't be vomiting either. They may disrupt the sutter line. Do not blow your nose to see if your ass possibly don't get a fucking infection because it will disrupt the sutter line. That's when that infection gonna hit you, and you might fuck around and get meningitis. So don't blow your damn nose. Watch for bleeding and any feelings of pressure or pain, okay? Follow the surgeon's orders regarding positioning. Some recommend lying on the operative side to facilitate drainage. Some prefer the client to lie on the non operative side to prevent fluid and blood accumulation and stretching of the suture line after grafting. Watch for any fever, any headache, vertigo, ear pain. All of that might be a select all that apply. Pressure over the implanted ear and notify the surgeon if any of that shit happen. Notify him ASAP, him or her ASAP. Although you can bathe, do not allow water to enter your ear. Don't let no damn water get in your ear. Resume your normal activities in about 2 weeks after being checked by surgeon. Okay, that don't mean go put Boots to set it off in his, you know, set it off on 115. Okay, that's not what that means. Okay, but you can go back to living, a bouncing life in about 2 weeks. All right. So, in practice data gathering, this is our data gathering in nursing 80-1. These are the key areas for monitoring and documenting the sensory system. Now, with general areas, nursing history, including information from family, presence of recent infections, meds, medication use, and recreational drug use, general appearance of eyes and ears, examination with ophthalmoscope or otoscope, presence of foreign objects, history of trauma to eyes and ears, documentation of cranial nerve function, neurologic status, signs of cardiovascular disorders like elevated cholesterol or hypertension. You need to know all of that shit. So you need to ask the patient about any of that. Because that's what we do as nurses. We're gathering the data to find out about this patient history and what's going on with their life. So visioning, well, with their health life. So visioning, eye documentation and data gathering, vision assessment with Snellen chart or similar tools like gross determination of visual acuity if person has poor vision. We're going to do screening for infection or injury, screening for color blindness, screening for visual field deficits, screening for extraocular muscle disorders, symptoms, and history of vision loss, and direct observation of disorders such as ptosis. What was ptosis again? You're right, drooping. Okay, so hearing and ear documentations and data gathering. Prolonged noise exposure. So presence of chronic respiratory or ear infections. Screening with audiometer or similar instruments. Complaints or symptoms and history of hearing. Okay, so this is for the hearing and ear documentation and data gathering. Prolonged noise exposure. Presence of chronic respiratory or ear infection. You need to know about that. Screening with audiometer or similar instruments, and complaints or symptoms and history of hearing loss. Find out about that information on that patient. Now, let's talk about this plan and the implementation. So this is what the fuck we gonna do as nurses when we go in there trying to make up plans, trying to set goals and come up with a game plan to help these patients. So nursing consideration for clients with sensory deficits include teaching and approaches to effective care for both client and caregivers or family, right? So whenever possible, you want to make short-term and long-term goals in conjunction with the client, caregivers, family, and healthcare team. The client with a hearing disorder may require assistance with communication, maintaining balance, and meeting social and recreational needs. Okay. I got a hearing disorder, but I need assistance with communication. I'm good with maintaining my balance a little bit. And then, well, I'm good with maintaining my balance. I ain't gonna put this shit out there like that in the world. And meeting social and recreational needs. Uh, I think I'm all right with that too. A client with hearing or vision loss may need assistance in dealing with the disorders, emotional aspect. Let me tell y'all something. I'm just gonna keep it real. Y'all be hurting my feelings sometimes, but I really don't give a fuck. But y'all do be hurting my feelings about because I can't hear. But I don't give a fuck. Okay, so help all clients to understand more about the disorder, the prognosis and the treatment, okay? Rehabilitation is designed to promote self care, provide pre and post operative care for the client undergoing eye or ear surgery. The suture line is delicate in many of these operations. You need to know that. The client and caregivers at home will need to understand ways to protect these delicate suture lines because many eye and ear surgeries are done on an outpatient basis. So it's very important that we're teaching, and they understand how to protect the damn sutter line. Because shit, you can fart in that damn thing and fucking disrupt. So make sure y'all teach them damn clients that and the family. So nursing considerations for the visually impaired client, right? So when caring for a client who is visually impaired and is hospitalized, including the following, will include the following. Encourage that client to assume responsibility for their own care gradually. Identify yourself when you enter the room. Don't come up in there uh, touching on them and shit. You gotta speak before you touch them. You don't want to startle them or whatever that word is. You don't want to frighten them. Speak in a normal tone. Don't go in there like Debo, scaring the fuck out the patient. Keep the call light within reach and place the bed in the lowest position. Place food on the plate in a clock position for every meal. Tell the person what is being served and where it is located. So I think it's like in the 12 o'clock, like in like let's say this o'clock. Let me start over here. Let's say this the clock, right? You'll say, I think it's like in the 12 o'clock, you have your green beans. In the 6 o'clock, you have your mashed potatoes. In the 3 o'clock, I think that's how I go. I could be dead damn wrong, but you have to tell it in the clock position. So I think I'm right. So when ambulating clients, walk slowly. The fuck you in a hurry for? Walk slowly and allow that person to take your arm and do not push them and see what happened to your ass. See if you don't lose your license. Orient the client to the location of objects in the room. Let them know about where the furniture is, where the door is, where the comb and brush and toothbrush and all that shit up. Where the water pitcher is. Keep those objects in place, in the same place. Don't go in there rearranging shit. That's not your house. Let the client know when you are leaving the room. Don't have them just sit in their room. They can't, I already can't see, and they in there talking to their damn self, and you been gone. Let them know when you're leaving so they can know, okay, she done left. Did she shut my door back? They need to know those things. When the client, I'm going to highlight that so y'all can know that. So when a client is visually impaired, just some simple activities can become difficult or overwhelming, unfortunately. So, for example, med administration or the postoperatively can present problems. The side effect of some eye medications, like Tomalol, that's like what you call it, a beta blocker, or bradyc. This the medications, right? They will call bradycardia, dizziness, and syncope or whatever it's syncope. I always fuck that word up. So discharging teaching must include the common signs and symptoms of medication side effects. The nurse also can offer suggestions such as get your ass a weekly pill reminder dispenser to help you, Mr. James. A home safety inspection should be performed. Scatter rugs, bitches gotta go. Doors halfway open, you need to do something with them. And packages left in hallways, all that shit is hazardous and will limit with limited or no sight. So y'all need to rearrange that shit and clean up in here so this patient don't have a fall or a bad accident. Individuals with a visual disruption often require rehab to resume self-care. The visually impaired individual may need assistance moving around and learning to navigate in familiar surroundings. Familiar surroundings will be the house. They still may need help. I know they may know they probably lived there for 45 years. They've been there since 1876. Okay. They still need to be reminded and be, have assistance on how the fuck to move around. Meeting daily needs, that's like preparing meals, shopping, hygiene, grooming, brings additional challenges. Moreover, the individuals may need assistance in finding new modes of transportation and may experience possible changes in employment. In addition, other options are available for visually impaired or non sighted clients. Okay. These options include computers, adaptation, Braille, if I'm saying that right, y'all know what Braille is. We're finna talk about it in a second. We're gonna talk about the guide dogs, them pit bulls and white canes. But they don't have to be a pit bull. I would prefer a pit bull for a guide dog. So with Braille, the Braille alphabet is a system of raised dots, right? It's a system of raised dots on the paper that correspond to the letters of the alphabet and punctuation marks. We know what Braille is. That's what blind people use to read. So one of the hardest things that a person who has only recently become visually impaired must do is to become accustomed to the inability to read. So learning to read Braille can be of assistance to many individuals with permanent loss of sight. The non-sighted person discerns these characters with the fingertips. Learning Braille takes patience. However, many books and other resources are available in Braille and will allow the person to continue to enjoy reading. Direct the person to local agencies for non-sighted for more info. Clients can use audiobooks or other electronic devices. There are recordings of books, articles, or magazines. Special Braille computers, keyboards are also available. Some computer monitors, magazines, newspapers are available in very large print for partially sighted people. Many are also available in Braille edition. So for the guide dogs, a guide dog, like I said, I would prefer a pit bull, but it is what it is. If it ain't no pit, it can't come up in here. But that's just me if I had to go to this. So as far as the guide dogs or whatever, um, they're called the leader dogs or seeing dogs. Seeing eye dogs. We done heard of that before. I done heard of the seeing eye dog, never a leader dog. It's used by many non-sighted individuals. These dogs are trained to recognize danger spots such as curves, obstacles, or holes. They learn to be careful of traffic. The dogs wear a harness fitted with a U-shape handle with the non-sighted person and can grasp. Clients and dogs then communicate through the movement of the harness. A non-sighted person who wishes to use a guide dog must live at a training center for some time to learn how to use and take care of the dog. The public, of course, these trained dogs in certain places. So they're allowed in restaurants, subways, hotels, and shit. Um, Airplanes, they got a place for them. If the client is not moving, the dog would just sit his ass there quietly. But this the thing right here. Do not go play. If you see somebody with a guide dog, don't go touch on that guide dog. I don't give a damn what kind of dog it is. It can be your favorite dog because you're going to cause that dog to become distracted, and that visually impaired person, they can be in danger. Don't go play. I don't give a damn. It don't even matter about, it's not even just about a blind person. You don't supposed to touch them damn dogs at all, period. Even if a person, some people have dogs because they have anxiety, you don't touch the dog. You do not touch, because they're called service dogs. You don't touch them dogs at all. You can speak to them or whatever, say, hey, how you doing? How was your day? But do not go touch them damn dogs. So a white cane. White cane is a signal. You know that big long white cane, they extra long or whatever. And guess who only have white canes? People who can't see. That is the only person that's going to carry a white cane. That's who it's for. Okay? So just know that it's a signal that the person carrying it is non-sighted. Only a non-sighted person is allowed to use that cane. And that person got the right of way over all traffic. So be patient when you see somebody crossing the street and they can't see. Don't be like, that motherfucker needs to get out the way. No, they got the right of way. Now bump them and see if your ass don't get sued. So some non-sighted persons, however, are reluctant to use a white cane unless absolutely necessary. One type of collapsible white cane that a client can carry in a purse or pocket is longer than a normal walking cane and has a metal or plastic tip that transmits sound. Okay, thus providing the person with some guidance about his or her surroundings. So y'all know when they take that cane out and it just unfold or whatever, and then they get to patting it on the ground trying to see where the hell it go. So as a part of the rehab process, non-sighted people learn to use these canes to locate curbs and obstruct and other obstructions. Those are some strong people to, only have a cane and go out in public. That's just amazing to me. There, that is so amazing. Okay. So I also want y'all to know that the nursing consideration for the hearing impaired client. So basically, a person with a marked hearing loss cannot hear sounds that warn of danger, right? So this person loses the thread of a conversation. That's me. And may ask questions or make comments that have no relation to the discussion. Because I say something, y'all be like, Janisha, that is not what she said. I'm like, okay, well, what the fuck did she say? Just tell me what they said. So sometimes a person with hearing loss lapse into a silence, baby, that's me, that makes them seem uninterested or inattentive. That's me all day. People who are unable to hear their voices, I can hear my voice. I'm loud and clear, shit. But the people that can't, they may talk loudly. I talk loudly, but I can hear my damn voice. Or in a monotone. Okay, that's like, um, how y'all doing today? They got to kind of talk deep. So in a monotone type voice, not no light little, baby voice or a very soft voice like Nurse Griggs. I love her, but I can't hear shit Nurse Griggs be saying because baby, oh, I can't hear nothing she be saying. And I'll be like, what, Nurse Griggs? And I'll be like, just, I'll find out. So many people are generally less tolerant of hearing loss than they are of vision loss. Thus, they may become impatient when asked to repeat their words. So y'all can handle the person that can't see shit, but Uh, y'all impatient with the person that can't hear shit. You know what I'm saying? Like, what the fuck they do that at? But anyway, bet. When caring for a client who is experiencing a hearing impairment, this is what you want to include. Get the client's full attention before speaking to them. That's what I be trying to tell y'all. That's what I be trying to tell y'all. Quit talking to me and walking down the damn hall. Quit doing that because I can't hear that shit. Face the client on the same level. You got to speak to me in my face. Do not speak to me from behind because that ain't how these God made my ears. Place yourself in good light so the client can see your mouth. I can read lips a little bit. It depends. Do not chew, smoke, or put objects in your mouth or cover it while you're talking. Because I'm ignore your ass because I ain't finna try to ask you what the fuck you said. Decrease background noises, such as the television or radio. Speak slowly and clearly. Repeat in time. This what pisses me off when y'all do that. Just speak clearly. Don't be talking all slow and shit like you chopped and screw. Just speak clearly. But they said speak slowly and clearly. Repeat entire phrases rather than specific words. Restate the conversation with different words. So when I tell you to repeat yourself, don't just say the dog. What about the damn dog? Say the whole damn thing. Use contextual clues such as objects, persons, and hand motions to facilitate the conversation and verify that the person understood the conversation. Y'all don't do that with me though, but it's all good. Individuals with impaired hearing may stubbornly refuse to admit that they do not hear well. Oh, I tell you, ass, I can't hear. So they may deny themselves to help. They may deny themselves the help of a hearing aid because of embarrassment. I ain't embarrassed. I just had a appointment today to try to get me some. I hope I'm approved. Hearing loss caused by advancing age. They ain't got shit to do with my age because baby, I'm in my 30s. Which is called presbyacousia. Presbycacia. I know that I messed that word up, but y'all put it in Google and learn how to pronounce it. So, hearing loss caused by advancing age cannot be restored, but there are ways of compensating, okay? So, with the hearing aids operate either on the principle of bone conduction or air conduction, depending on the type of hearing aid you get. So, the device amplifies sounds. A tiny receiver is going to be inserted in the ear, and and earpiece is molded to the wearer's ear. Many hearing aids today are so tiny your ass can't even see them. The healthcare provider will determine whether a hearing aid will help and which type will be most beneficial. Unfortunately, a hearing aid is usually less effective in improving hearing than glasses are in improving vision, unfortunately. Because I can have hearing aids all day and probably still can't hear shit. Adjusting to a hearing aid takes time and patience. Normally, an individual can adjust to and focus attention on specific sounds such as human speech. Like I can hear deep voices, but not light voices. Like I said, difficulties that clients encounter when wearing hearing aids includes the resultant amplifications of all sounds, including background sounds. So these people with hearing aids, they hear every damn thing. They hear your damn stomach growling. They hear your ass about to get ready and fart before you even fart. So they can hear everything. So these sounds can be distracting and annoying as fuck. However, the client can overcome difficulties with preservance and by wearing the aids at all times, not just occasionally. Wear that shit all the time so you can preserve your damn ears. The earpiece will be washed every day with mild soap, dry the fuck out of them. Pipe cleaner will help to clean and dry the cannula because you got to clean your ears out. Make sure you check your batteries every damn day because it's something about them damn hearing aid batteries, baby. My mama stay sending me to the store for them because she wear hearing aids. So getting used to wearing a hearing aid and learning to adjust to it take time and patience. And I'm all for it, baby, because I need them. And that's so doggone expensive. I just pray to God I can get some hearing aids. I pray that they approve me for them hearing aids. Okay. So I can stop getting into it with y'all ass because I can't hear. But anyway, y'all, speech reading individuals with a hearing loss may benefit from they may benefit from lip reading and facial expressions. To understand lip reading, the hearing impaired person must directly face the speaking person. Like that's what I said. Y'all got to face people. Don't talk to them from behind. You have to face people that cannot hear sign languages. I don't need none of that. I mean, but let me read it. Another means of communication is sign languages. Sign languages uses specific movements of the fingers and hands to form letters of the alphabet, as well as concepts or words. Facial gestures, movement of the arms, and postures of the body combined with words to form a complete complex language. We know it is ASL in America. That's the most common sign language. It's called American Sign Language, so ASL. There are many varieties of language depending on the client's country of origin. Now, just know sign language is not universal. So if you go over there to the UK, they they use British Sign Language. So don't go over to UK using the US Sign Language because that shit don't work like that. All right. So nursing alert. Lions International target vision and hearing improvement as a major goal. If your ass come into contact with someone who needs eyeglasses, a guide dog, a pit bull guide dog, or a hearing aid or surgery, but cannot afford it, put the person in contact with their local lion club. All right. So evaluation. So what are we gonna do? Y'all know what we do in evaluation. You're trying to see if the shit worked out, whether it's with the glasses, the eyes, the surgery, the hearing aids, the damn dog, the pit bull guide dog. We just trying to see if the shit worked and how the client responded, the prognosis, any complications, and the client's responses. That's all it's talking about. So the eye and the vision disorders. Now, with the eye and vision disorders, several specialists. Hold on, y'all, because my damn phone keep going on. Um, Several specialists are involved in treatment of the eye. Right? You got the ophthalmologist. What they do, y'all? Eye, opto, opthel. This is something that you can keep him look at for when you take that dog home when you trying to learn about the cranials nerve system, those different cranials. I think it's like 12. I don't know. It's several of them. I don't know if that's number one. I forgot. I know it's like optic. It's somewhere up there. But ophthalmologist, that's the eye doctor. He's a medical doctor. You got the optometrist, opto, optometrist. This doctor is the eye disease as well. But he has received a doctor of optometry degree following undergraduate and graduate studies. But the ophthalmologist, his ass went through all, baby. He went through it, baby, and he became a medical doctor. He a doctor too, but he did undergraduate and graduate studies. And this individual is licensed to examine your eyes and prescribe eyeglasses or contact lenses and administer treat some eye disease with meds. But this doctor, the medical doctor, he can cut your shit open and fix it, or remove it if he can't fucking fix it. The ophthalmologist. So y'all need to know the differences between this. I definitely would. This one, he can examine eyes, give you medicine. The optometrist, he can examine your eyes, give you medicine, prescribe you medicine, and contact lenses in many states, and treat some eye diseases with medication. That's all he can do. An optician, what they do is responsible for grinding lenses and fitting spectacles as specified specific specified by either the ophthalmologist or optometrist. Okay, so know each one. If I was y'all, I would know each one of their responsibilities. Something like this would be on the test. I will not, because this is so simple. So the ophthalmic technicians, what they do is they are certified. These are technicians. So they're certified by the Joint Commission to assist the ophthalmologist in performing tests on the client. So those are the ones before you even come up in that bitch, they're gonna do this. Um, we're gonna do the smelling chart now. Those are the ones that do that. You know, uh, I think those technicians put the drops in your eyes too, so they can do the stuff. I think I well, at LSU they do. Now they probably ain't got no business doing it, but then again, I don't know. I don't know. So that's the ophthalmic technician. So just know they're certified by the Joint Commission to assist. They are just basically assistants, okay? CNAs of the eyes. So visual changes in visual acuity are very common, affecting most people sometimes during their lifetime. Visual, and it's mainly when the person turns 40 years old. When they hit 40, it's some changes going on. I mean, it can be before then, but it's very, very common in 40 plus year olds. Visual changes may be corrected simply with lenses or surgery, or they may increase in severity until the person is unable to see light at all. The nurse is responsible for identifying early changes, teaching the client how to preserve vision or adapt to changes, and assisting the person when the vision is impaired. So that's what we're responsible for. We're responsible for identifying early changes, teaching the client how to preserve vision or adapt to changes, and assisting the person when vision is impaired, right? So with refractive errors, vision occurs when light rays of an image, vision. Okay, we're talking about refractive errors. I'm sorry. Let me slow down. Refractive errors. Vision occurs when light rays of an image pass through the lens and come to a focus point on the retina, right? So from here, the neurons send that signal to what? The brain. So it's going to spark an impulse to the brain for interpretation. So, boom, when that light hits your eye, because all it is, like everything that we look at is, it's just light bouncing off of something, and it bounces into our eyes. It's a beam into our eyes, and it give us an image like, oh, this is what this look like. And then boom, it goes into our brain, and we're like, oh, them some big ass titties. So, our brain is going to interpret it. So, refractive errors results when light rays focus in front of or behind the retina owing to variation in the shape of the lens. Okay. Refractive errors result when light rays focus in front of or behind the retina owing to variations in the shape of the lens. So the person experiences blurred vision or other changes in acuity, holding objects at a distance, squinting, and headaches, or some signs of impaired acuity. So know the signs of impaired acuity. Shit, acuity. Holding objects at a distance, squinting, and headaches. Holding objects at a distance, squinting, and headaches. Those are signs of impaired acuity. That may be a select all that apply. Common refractive errors are myopia, nearsightedness, hyperopia, foresightedness. That ain't supposed to be way over there. Astigmatism. And astigmatism is an abnormal curvature of the cornea or lens. And presbyopia, this is loss of the lens elasticity and accommodation owing to the aging process. So that's about getting old as fuck, and that's what happens. So right here you have the box table 80-1. So refractive errors of the eye. We got the refractive error, the cause and the result. Myopia, elongation of the eyeball, light rays focus at a point in front of the retina, blurred, distant vision, right? That's what's going on in myopia. In hyperopia, read this very slowly so y'all can remember what the shit do. So in hyperopia, you got shorter than normal eyeballs, right? And the result is the light rays focus at a point behind the retina, blurred close vision. Then you got astigmatism. And the cause of astigmatism is unequal curvature in shape of lens of cornea. And the result behind it is um, light rays focus on two different points on the retina, distorted vision. And then presbyopia, presbyopia, loss of elasticity of lens, poor accommodation, light rays. What the result is, light rays focus at a point behind the retina, decrease close vision. Damn, I forgot about my Willis Night Ice. Shit. I'm gonna go up there and get this all. Okay, hold on. So let's talk. Know this chart. Know that damn chart. I will go over it again, do it yourself. So, correction of refractive errors. Refractive errors, which cause the most common changes in normal vision, are first identified by the Snellen test. The refractive, so just know the correction of refractive errors, just know with refractive errors, they're going to be most common changes in normal vision, and they're going to be first identified by a Snellen chart or a Snellen test. The refractive examination is going to point out the degree or pinpoint the degree of error which is necessary to determine the treatment, right? It's going to narrow this shit down and say this is what it is. So corrective lenses, eyeglasses, or contact lenses, these are going to be the most common treatment for refractive errors. Corrective lenses, contact lenses are the most common treatment for refractive errors. That might be on the test. The lenses are shaped as either concave or convex. One of these words mean bi, biconcave or is it biconvex? One of them mean like it's not round or something. The lenses are shape is either yeah, it's they're round. They're going to be round. It's concave or convex. The lenses are going to be round. That's what that word means. And the refracting, bending the light rays to focus on the retina. Okay, so keep in mind that eyeglasses. Oh, no, no, keep in mind. Let's talk about eyeglasses now. Now, with the eyeglasses, uh, they're going to be prescribed to correct the refractive errors of hyperopia, astigmatism, and presbyopia, and for some vision, like legally blind individuals. Okay, so bifocals and things thick, 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 thick. And these are two lenses in one. They may be prescribed to correct the problem of presbyopia. Bifocals are thick, 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 thick. They're two thick ass lenses in one, and they may be prescribed to correct the problem of presbyopia. And what we said presbyopia was again, it's going to be like in the the older you get, loss of lens elasticity, accommodation owing to the aging process. All right. So each eyeglass lens has two parts. One part correct the defect in the near vision, and the other correct the defect in the far vision. Okay. So remember that two glasses with two each eyeglass lens has two parts. They're going to correct one part is going to correct the defect in near vision. The other one is going to correct the defect in the far vision. Trifocals are also available and provide an additional option for vision correction. Contact lenses. Contact lenses are designed to fit directly on the cornea where they float on a layer of tears. Contact lenses may provide better vision than eyeglasses by eliminating minifications or magnifications of objects. Poorly maintained contact lenses hygiene can cause significant problems, including corneal ulceration. Hard contact lenses are made of rigid gas permeable plastic, RGP, and or paper thin. They are kept in place by capillary attractions and by the upper eyelids. Clients usually wear them daily. The lenses require special cleaning, rinsing, and storage solution for care. Soft contact lenses are made of hydrophilic plastic of a larger diameter and greater flexibility than RGP lenses, which are RGP lenses are what again? Rigid gas permeable. And soft contact lenses are made of hydrophilic plastic of a larger diameter and greater flexibility than RGP lenses because RGP lenses are hard as fuck. So soft contact lenses are more likely to be damaged by handling because they can easily tear. Extended wear soft contact lenses allow oxygen and carbon dioxide to pass freely through the lens. These lenses can be worn up to 2 weeks, but guess what? They put you at a greater risk for infection than daily wear contact lenses. Okay, some soft lenses are disposable and are discarded after an established period for a new set of lenses. Many people take contact lenses for granted. Contact lens wearers must realize that prolonged wear or improper care can cause infection, particularly conjunctivitis and injury to the sclera, such as ulcerations. In some cases, blindness may result from infectious keratitis, inflammation of the cornea. Cautions client not to put the damn lenses into the mouth. Why the fuck would you want to put breath on your damn contact lenses? Do not put breath on your contact lenses. Meaning, don't put your damn mouth, your freaky ass tongue that you done probably had on. I ain't finna go there. Because if this get out, I don't want them to think I'm just real fucking nasty with my mouth. So Um, don't put your damn shit, put them contact lenses in your mouth, and you've been having oral sex all your damn life. Don't do that. Doing so can transfer sperm and all that other shit, unwanted pathogens into the eye. Um, oh Lord, who in the hell putting breath on contact lenses? So keep in mind that the greatest danger with the use of any type of contact lenses is the possibility of injury or infection of the cornea, and which may can permanently affect vision. So just keep this shit in mind, y'all. In the case of accidental or unconsciousness, the wearers could become blind if hard contact lenses are not removed. When the eyes are closed, tears cannot circulate freely, and corneal ulcers can quickly develop. For this reason, clients should not wear contact lenses while sleeping unless they are designed for continuous use. Okay, that's when they should wear them. If they can wear them if they're for continuous use, like the extended wear. But if they're not designed for that, don't try to make them bitches do what they're not supposed to do. So if the person wearing contact lenses is busting the damn face right in the eye area, injury to the cornea may result. Contact lenses rarely break while they are in place because the eyeball will give with the eye. Okay. So what else? What we supposed to know? However, in the event of injury, severe swelling, or infection, a healthcare provider may need to remove lenses. Surgical surgery, surgical correction is done. My bad. Surgical correction is done by refractive surgery. That's surgical alteration of the corneal curvature, in which a laser or other microsurgical knife reshapes the cornea. Another procedure is radial keratotomy. And what happens is this is going to be like in which the partial thickness, the radial incisions are made in the cornea to correct the refractive error. So when you see Tommy, you know an incision has been made. Photo. I don't know why I didn't um highlight that. Photo. Ooh, shit. Okay, photorefractive keratotomy, PK, well, PRK, and laser assisted insight keratomyeleusis. That's LASIK, okay? We know about LASIK. Or other procedures that correct refractive errors. Let's talk about these inflammatory and infectious disorders. Now, with conjunctivitis, we call it pink eye. Everybody know what is pink eye. We always been told when you go in there and you don't wash your hands after you done took a shit and you go in there and rub your eye, then boom. This what the fuck happened. This what the fuck happened. Okay? And so this is the inflammation of conjunctivi, the membrane lining the eyelids and covering the sclera. A bacterial, viral, or an allergy may cause conjunctivitis. Infectious conjunctivitis is very contagious. It can develop in one eye and easily be transferred to the other eye when the eye or face is touched. Contact lens is also a risk factor. Conjunctivitis causes pain, redness, swelling, itching, and sometimes purulent discharge. Okay. So know the what it causes: pain, redness, swelling, itching, and sometimes purulent discharge. The discharge may be so damn thick and copious, meaning it's a lot, that the eyelids stick together. Antibiotics, eye drops, or ointment, or prescribed for bacterial infections and antiviral medications for viral infection. Baby, don't think just because my shit be painful, my shit be red, My shit don't itch. I don't have no pus. Okay. So don't get it twisted. That ain't what I have. Y'all don't know my damn business. And this is I do not have conjunctivitis. I'm not on no damn antibiotics either. So make sure that you wash your hands properly. Use gloves. Proper cleaning of the client's linen are essential to prevent the spread of infection because this shit can spread conjunctivitis. So typically, allergic conjunctivitis is bilateral. So if it happened in one eye, it's going to happen in the other one. That's what bilateral means. Um, that's that's allergic uh, conjunct, conjunctivitis. Infectious conjunctivitis may be unilateral, meaning that shit only happen in one eye. Treatment of allergy related conjunctivitis includes, I think y'all would need to know this. That's something very important to know. Treatment of allergies treated. Uh, no, treatment of allergy related conjunctivitis include you're going to avoid the offending allergen, take antihistamines, and undergoing desensitization. Many over the counter antihistamines and prescription eye drops are helpful. Baby shampoo or saline solution irrigations or warm soaks may be, helpful to remove the discharge and reduce the swelling and decrease the pain and itching. Giant capillary conjunctivitis is GPC. It's a type of severe conjunctivitis, and it can be a result of chronic, long term of contact, long term use of contact lenses. They talk about that in 73, but we ain't going back to 73. So GPC can generally be successfully treated by discontinuing wearing of contact lenses for several weeks or months. Key concept to remember: teach that client not to rub the eyes, which can lead to corneal scoring. If eye drops are used, teach the client not to touch the eye with the drop per. I'm talking about with the drop per. Hold on. That's probably one word. With the dropper, which will contaminate the solution. Discard unused or partially used eye drops because the solution can become contaminated. Okay. Now I don't know this word. Trachoma. I'm gonna say trachoma. Trachoma is another form of conjunctivitis found in hot, dry climates. The shit really don't even happen in the United States like that. It is the cause, its cause is the organism. Y'all see it? Trichomonas. Okay, so trachoma. Yeah, trichomonas. Oh, look at me talking about trichomonas. That ain't what the fuck they say. They say chlamydia trachomitis. Trachomitis. Just making shit up. So it look like trichomonas, but chlamydia trachomitis, which may also cause the infection, inclusive conjunctivitis, right? So trachoma is highly communicable and it's one of the world's leading causes of preventable blindness. Treatments include topical and systemic antibiotics, which are very effective. Trachoma, like I said, barely happening in the US. So you're going to give them topical and you're going to give them systemic, meaning they're going to pop some damn antibiotics and they're going to put antibiotics on their eyes. So they're going to pop them damn antibiotics like some beans to clear that shit up. So with blepharitis, blepharitis, who these words? Blepharitis. Y'all know what the fuck I'm talking about. This word right here. Inflammation of the eyelid, okay? It's caused by excessive dryness of the eyes, excessive oiliness of the skin, or infection. Now, this condition is usually characterized by red lid margins and purulent drainage. Purulent drainage. So that's pus, right? So treatment consists of applying warm packs to the eye to help loosen crusted drainage. That's what you're going to do as a nurse. Get them some warm packs to help loosen up that crusty shit around the eye. Cleanse the eyelid gently with a mild soap and water once or twice a day. And antibiotic hypothalamic ointment may be prescribed to resolve infections and prevent recurrence. Hordeolum, or I don't know why they call this shit. It's a sty, baby. It ain't nothing but a sty. It's an acute inflammation of an oil or sweat gland of the eyelid. Styes are red, raised, swollen, and painful. They contain pus. After the area drains, pain is relieved and healing begins. Treatment includes applying warm, moist compresses and a topical antibiotic ointment to the area to help localize the infection. In severe cases, the abscess is incised and drained. Tissue climb not to squeeze the sty, which could spread the infection. I remember back in the day, my mom used to say that styes were from pointing up at the damn moon. But anyway, so to this day, I still believe I'm pointing at no damn moon. Uh, but anywho, chalazion, chalazion, I think that's the word, is an accumulation of lipid, which is fatty material from a chronically obstructed Maybo, Maybom, oh shit, Meibomian, which is a sebaceous gland, and I know that damn word. It's a sebaceous gland found on the eyelids, so I guess it's a fatty material, like it's oily. So it's an accumulation of lipid fatty material from a chronically obstructed may, meibomian sebaceous gland from one of the eyelids, right? If the lesion is small and doesn't affect vision, you ain't got to do shit. However, if that bitch become infected or interferes with vision or eyelid closure, we're going to slice and dice that bitch up out of there. So we're going to incise and drain it. And, that shit may be necessary. So let's talk about keratitis. With keratitis, it is an inflammation of the cornea, because you see itis in that bitch. So the cornea is inflamed, and it can be caused by bacterial, viral, fungal, or trauma. Okay. Herpes simplex keratitis. This is the most common cause of unilateral vision loss from infectious keratitis in the United States. The symptoms are going to include pain, photophobia, sensitivity to light, blurred vision, purulent drainage and redness of the sclera, corneal ulcerations is a common sequelae, meaning a common result. The corneal ulceration is a common sequelae. So basically, when we say sequelae, that means so keratitis been doing what the fuck it's been doing, and the due to keratitis doing what it's due to that bacteria infection, and it caused all those other issues. Now this is the result of that, which is corneal ulceration. So sequelae means it's just a result of something else that already been going on, and now this shit didn't happen. Y'all know how it is. Like, damn, I done had I already did um shit was late for school. Then damn, I done ran out of gas. So that's basically what sequelae means. Some already was going on, then boom, something else did happen. So after culture studies are done, treatment consists of eye drops to dilate the pupil. Okay. After culture studies are done, treatment consists of eye drops to dilate the pupils. Fortified antibiotic drops may be given hourly for bacterial disease. Ain't that some shit? You gotta get your damn shit hourly when you fucking with keratitis. Antiviral, antifungal therapy, as necessary, may be given for viral or fungal causes. Okay, so let's talk about. We got 16 pages to go. We almost done. Structural disorders. Structural eye disorders may result from the aging process, injury, or a nervous disorder. They include. Well, after this, I'm gonna take a break and I'll do the rest of these damn pages tomorrow. So I hope the damn video don't stop. But anyway, structural disorders. Structural eye disorders may result from the aging process, injury, or a nervous disorder. They include, and we're talking about structural disorders now, okay? They're going to result either from aging, injury, or some going on with the nervous system. So they're going to include ectropion. Ectropion. This is an outward turning of the eyelid. It's caused by the aging process. The eye is no longer able to drain effectively, and tearing occurs, surgical intervention is necessary. Okay. Then you got entropion. Entropion, that's inward. An inward turn of the lid margin is common in older folks. The lower lashes turn inward and are often not visible, but they irritate the conjunctiva and the conjunctiva and cornea. And corrective surgery may also be necessary. Then you got ptosis. We know that's the drooping of the upper lid. Ptosis may result from muscular weakness, damage of the ocular motor nerve, of interference with the sympathetic nerves that maintain the lid's smooth tone. Depending on the cause, corrective surgery and or corrective of the neuro disorders may be necessary. So the way I remember that, because I know that shit might be on the test, this is what made me remember this one. It say inward entropion, inward entropion, ectotropion, outward. So I'm looking at it like exit. I know it's just called ec, but I'm looking at it like exit. Ectotropion, outward. Glaucoma, right? Ooh, now this is what they trying to talk about. I'm like, dang, this is some fucked up shit if it is what I got. Cause baby, y'all just don't know. And I take glaucoma medicine. Shit be having me run to the damn bathroom. I be having to can't put on no shoes and nothing, Jesus. I had to run for my goddamn life. Um, Glaucoma is a condition of increased fluid, aqueous, the aqueous humor. That's the fluid that's made by the ciliary body in the back of the eye. And so the glaucoma is a condition of increased fluid, which is the aqueous humor, and it's gonna put that pressure in the eye. That's we know it as intraocular pressure due to too much aqueous humor and uh what's the name? The trabecular meshwork is blocked, so this shit ain't going out like it's supposed to do down the canal. So it's just building up in your eye. It has an insidious onset, usually occurring after the age of 40. Baby, I ain't 40 and I got that shit. Well, I might, but I ain't gonna claim it. And having familial tendencies, right? So it can be genetic. Now, glaucoma is the leading cause of blindness in the United States. That is the leading cause. That's why I highlighted that whole sentence because glaucoma is the leading cause of blindness in the United States. Now, a disturbance in normal balance between production and drainage of eye fluids cause glaucoma, leading to an increase in intraocular pressure. The increased pressure of glaucoma is also known as ocular hypertension or high intraocular pressure. Chronic elevated intraocular pressure permanently damages the retina and the optic nerve. If left untreated, visual changes and blindness will and the fuck can occur. Early diagnosis and treatments are, is very, very important trying to prevent the loss. Angle closure glaucoma, this is the most common type. Um, okay, so let me read about this. So angle closure glaucoma, this is the most common type. And in this condition, the drainage of the aqueous humor through the trabecular, which is the supporting meshwork, is located in the anterior chamber of the eye. It's the front part of the eye, but it's in the corners, in each corner, and is inadequate. No, yeah, it's in each corner of the eye. So is inadequate. That shit ain't working. So now the pressure is building up in the eye. So when that bitch is when the trabecular meshwork is like, let's say it's clogged up, when it's blocked, that's when the pressure build up in the eye because the aqueous humor it can't drain like it's supposed to. Both eyes are commonly affected. The onset of angle closure glaucoma is slow with gradual loss of peripheral vision. It is often diagnosed at a routine eye exam. Um, Often symptoms are absent, mild, or intermittent. Therefore, a serious vision loss may occur before the condition is discovered. When symptoms occur, they include eye discomfort, temporary blurry of vision, reduced peripheral vision, and headaches. Late signs are the appearance of halos. around lights and central blindness. Okay, those are the late signs for angle closure glaucoma. Treatment, they're going to be treated with an eye drop to increase aqueous um, outflow. So they're going to get something like, such as ACE. Okay, it say ACE tazolomide. I take methylozomide. So it's in the same category. It's a carbonic anhydrase, if I'm saying it right. So that's the drug classification of an acetazolamide. And that shit cause you go to the bathroom and shit your ass off. So to decrease production of aqueous humor, that's why we get it. That's why they do that. Beta adrenergic blockers such as Temelol and all the rest of these are used as well. See, we're talking about hypothalamic carbonic anhydrase inhibitors such as brinzolamide. It's the same thing. It falls under that category with the mides. Um, all these, you see them, dorzol, dorzolamide. They reduce intraocular pressure by suppressing, hold on, they're going to do it by suppressing the rate of aqueous humor formation. They are effective ocular hypotensive agents, but may have significant systemic side effects if used for long-term therapies. Okay, they're effective ocular hypotensive agents, but may have significant systemic side effects if used for long-term therapy. Damn, I didn't know that. So hypothalamic prostaglandins, um, they reduce intraocular pressure. Y'all see what they are? The travoprost, pros. You see that pros at the end? You know those are prostaglandins. Pros. They reduce intraocular pressure by increasing the release of aqueous humor through the trabecular meshwork. Laser treatment is often used to facilitate the drainage of aqueous, so it helps the drainage of the aqueous humor. In some cases, filtration surgery is going to be required. Now, primary open glaucoma angle, I mean, you don't want no glaucoma, period, but if you had to get glaucoma, wanted to stay at the primary open because I'm going to tell you why in a second. Well, I'm going to tell you why now. The difference between primary and closed is acute. Oh, well, shit, I must don't have it. I must talk about this shit at the top. Y'all did. I did. I guess with angle closure glaucoma, that's closed glaucoma. This is very bad. This shit is like acute. It come on suddenly, and you got to fix that shit ASAP. Now, primary open glaucoma, what it does is when the aqueous aqueous humor is blocked by a bulge of the iris at the anterior chamber. It's like the iris. That's where you get your eye color at. Like when the pupil, basically, it's like when the pupil dilate, the iris kind of would say the iris kind of dilate as well, or it stretches the iris, and then the iris blocks the trabecular meshwork. And you know that's where the fluid go down. The aqueous fluid goes down into that and goes through the canal, right? But when that iris is blocking it, you got a buildup. So that's primary open angle. So the result is an accumulation of aqueous humor with resultant increased intraocular pressure. The cause is unknown. They don't know why the shit do it. Um, However, one theory identified possible accumulation of mucopolysaccharides in the trabecular meshwork. Okay, risk factors, that's just an assumption. So, risk factors include diabetes, cardiovascular disease, hypertension, which is me. I have intraocular hypertension, and prolonged use of topical periocular inhaled or systemic. What's that? I guess there's supposed to be a comma right there. Or systemic corticosteroids. Those are all risk factors. Primary open angle glaucoma occurs primarily in patients older than 40. I probably would know this right here. What is the risk factor for someone who has primary open glaucoma? Diabetes, cardiovascular diabetes, well, diabetes, cardiovascular disease, hypertension, prolonged use of topical, periocular, inhaled, or systemic corticosteroids. Folks over the age of 40. It is 3 to 4 times more common in black folks than in any other color, where it's saying white. Um, the client may not be aware of any vision. They may not be aware of any vision changes at their time, but if that shit close up, hell yeah, they're gonna have some. They gonna know if it was closed, if it was like closed ankle glaucoma. So they may not have any vision changes, they may not be aware of any, but the IOP will fluctuate or increase, and there will be visual deficit and central field vision loss late in the disease. Treatment is going to include hypotensive agents to decrease aqueous production, such as beta adrenergic antagonists. Okay, these are the LOLs. You see a beta, think of like metoprolol. I take that, but that's from my heart rate down. So that's why you have to watch out when you give somebody a beta adrenergic and they already taken a beta adrenergic for the heart. Those are the LOLs because they can decrease the heart rate. Biotics such as pilocarpine, that's a dilator. Ain't that a dilator? When I look at that, yeah. When I look at that, oh, I think of a dilation. I think of the pupil getting small. So with the pilocarpine and all the rest of these carbonic anhydrous such as oral astazolamide, like those mides I told y'all about, or methazolamide, that's what I take. What they do is suppress the aqueous inflow. And the prostaglandins, all those things that process the end, increase aqueous outflow. Okay, so these are gonna the carbonic anhydrases are going to suppress the flow. You might don't need to know that. This isn't this may not be um y'all know, but this med surgery. I don't know how it is. Early surgical interventions is indicated. It, excuse me, it consists of an iridectomy, meaning they're going to have to remove a portion of the iris. And this procedure involves making a dam hole in the iris so that the aqueous humor can flow. Oh Lord, uninhibited, meaning it's not blocked from the posterior chamber and in the back of the eye to the anterior chamber. Iridectomy is performed with the laser or by traditional surgery. Now we got cataract. I feel like talking about that. I can run through cataract. Let me see. I'm gonna stop right here. Tired. Pick up tomorrow. Okay, so let's talk about these cataracts. The cataract is an opacity or cloudiness of the lens. We know what cataracts look like. Um, they're in the book. Because light entering the eye must pass through the lens to reach the retina, vision is impaired, right? So when the lens loses its transparency, okay? So because light entering the eye must pass through the lens to reach the retina, vision is impaired when the lens loses its transparency. Yeah, it can't reach it because it's cloudy or opacity, same thing. So the earliest sign of a cataract, patient may have halos around the lights. That's the earliest sign of a cataract. Client may have halos around the light. The person may also notice decreased visual acuity and double vision. Cataracts may be age related, traumatic, complicated, or toxic. Age related or senile cataracts results from chemical changes in the protein of the lens in elderly adults. Traumatic cataracts, what it results from is a foreign object that can, cause the aqueous or vitreous humor to enter the lens capsule. And then complicated cataracts, you got those, they result from systemic disease. Complicated cataracts, these are the differences with the cataracts. So, but complicated cataracts, they result from systemic disease such as atopic dermatitis. You got metabolic disease such as diabetes or hypoparathyroidism, or secondary to an associated disease of the eye such as retinitis pigmentosa or retinal or retinal detachment. And lastly, the toxic cataracts, they're going to come from a drug or chemical toxicity. Okay, that's a drug or chemical toxicity. Complicated systemic disease, traumatic foreign object, and then age related chemical change in the protein of the lens, and elderly clients. I'm going to highlight elderly clients. Okay, so with the treatment, the only remedy for cataract, you got to get some bitches removed. So surgery to remove the lens. This procedure is one of the most frequently performed surgeries in the U.S. Okay, cataracts is usually done as an outpatient procedure using a local anesthetic. In the person with cataract visual acuity, cannot be corrected to better than 20 to 60 with eyeglasses is an indication for a cataract extraction. However, though, the main indication for surgery is when the client complains that vision loss interferes with activities of daily living. Several types of surgical procedures are used to remove the lens. You got the extracapsular extraction. It involves removal of the interior capsule. It's going to be the interior capsule of the lens, followed by the intact removal of the lens nucleus through a larger incision. Another alternative would be the ultrasonic fragmentation, emulsification of the lens nucleus through a smaller incision. An intraocular lens, 10 liters implant, is used with almost every procedure. So let's talk about these age degeneration, with age related macular degeneration. With the age macular degeneration, it can cause loss of central vision and partial total blindness. That's what happens with age related macular degeneration. It causes loss of central vision and partial or total blindness. The macula is central, it's the central portion, macula central. I think I'm gonna remember that C and that C. So macula central portion of the retina that surrounds the optic disc, that surrounds the optic disc, which is responsible for sharp central visions. Okay, the macula is the central portion of the retina that surrounds the optic disc, which is responsible for sharp central vision. The macula is necessary for seeing fine details or to see objects clearly as is needed for reading or driving. Macular degeneration is a painless disorder that generally commences in the fifth decade and is the leading cause, well, yeah, it's the leading cause of vision loss in clients over the age of 60. Some forms of macular degeneration affect younger population. Okay, so we said leading cause of loss in vision or in clients over the age of 60. So the risk factors for AMD, which is age-related macular degeneration, include the formation of yellow cellular deposits or debris called drusen. You may have to know that. Drusen accumulates between the retinal pigment and the choroid, the choroid layer, which supplies nutrients to the macula. Drusens are often seen before vision changes and may be the sign of AMD. The disorders can advance slowly or rapid and may lead to blindness in the eye, well, in both eyes. In early stages, some individuals may not notice the visual changes or rationale the changes by thinking, shit, I'm just getting old as fuck. Signs and symptoms include blurred vision, difficulty seeing faces or discerning colors, distorted vision, drastically decreased visual acuity, and the presence of drusen. Additional risk factors are going to include smoking that damn nicotine, aging, family history, high blood pressure, high cholesterol, fat, and female gender. There are two forms of age-related macular degeneration. I will remember that if I was y'all. Right. There are two forms of age-related macular degeneration: non-exudative or dry macular degeneration, and exudative or wet. Now, let me tell you about the non-exudative, which is the dry one. This is the dry macular degeneration, the non-exudative. So it progresses slowly, and there is no cure for it. All forms of AMD begins with dry form. All of them. Signs of the disease, including, well, signs of the disease include needing more light to read, increased difficulty with reading, and noted blurred vision in the middle of the vision eye, where the vision field. I remember that too. Okay. Treatment may include high doses of antioxidants such as lutein. Exudative, that wet macular degeneration is the formation of fragile blood vessels behind the macula that can leak and cause vision problems. One of the first signs of the disease is wavy lines. It's going to be wavy lines noted in the vision field as can be tested on an ocular testing grid. Exudative macular degeneration progresses quickly and medical attention must be sought. You got to get medical attention or blindness can occur. That's important to know. It's just like that closed eye glaucoma. I'm going to highlight that whole thing because I think that's maybe on the test. Testing for exudative AMD may include a fluorescein angiogram. What I told y'all the angiogram was again, it's like it's going to involve dye and it's going to involve blood vessels, which involves a peripheral injection. I already told you of a specific dye, monitoring of the photos, looking for blood vessels leaked into the eye. And then the treatment option include laser therapy, photodynamic therapy, eye injection, and vascular endothelial growth factor medications such as Lucentis. Y'all see all the medicine. Um, so multiple lasers or photodynamic treatments may be required as they are not a cure for the disorder. So advanced AMD does not respond to treatment, which means that early recognition and treatments are necessary to prevent or delay vision loss. As for the trauma, as for this trauma of the eye, that's contusions or hematoma. That's a blunt injury to the eye, may cause swelling and bleeding into the soft tissues surrounding the orbit, resulting in a contusion or hematoma, also known as a black eye. Um, Apply a cold pack for the first 24 to 48 hours to decrease the bleeding and edema. When the swelling has stopped, usually after 24 to 40 hours, you're going to then use the warm pack on the site to hasten the absorption of the blood from the tissue. So I think we need to know all that. How to heal a black eye, basically. Foreign bodies. Foreign bodies may be external or internal. So external foreign bodies are found on corneal or conjunctival surface. Internal, hold on, internal foreign bodies, external foreign bodies, they're going to be found on the corneal or conjunctival surface. They're found on the surface. And internal foreign bodies sound like they're going to be on the inside. So they penetrate, yeah, they may penetrate the cornea or sclera and enter the inside. Yep, because that's internal, inside of the eye. External, they're on the surface. I mean, they're on the outside. So the latter most often results from pounding metal or on metal or trauma, pounding metal on metal or trauma, such as gunshots. To prevent damaging internal ocular structures, never attempt to remove a penetrated object from the eye. So, person gets shot in the eye, they should not try to remove that. They need to go to the doctor. If an object is embedded in the cornea, a topical anesthesia may be ordered for several ocular pain until the object can be removed. It can be very painful. So, they got to go to the doctor and get it removed, but they have to, put topical anesthetics on there to try to remove it. Ultrasounds may be used to locate an embedded foreign body, and an electromagnet or surgery may be necessary for removal. Hyphema. With hyphema, this is a hemorrhage into the anterior, that's the front part. The anterior chamber of the eye is usually caused by blunt trauma and can lead to glaucoma and vision loss. Hyphema, it can lead to glaucoma or vision loss. It's a hemorrhage into the anterior chamber of the eye. Client should report the signs of bleeding in the eye ASAP. Treatment consists of mydriatic, which are dilated. I remember mydriatic by this D word. The D is for dilated, mydriatic, or meiotic, constricting. The way I remember that, I'm looking at a pupil. It's O is the constricted pupil. So meiotic constricting meds. That's the treatment for hypema or hyphema. Occasionally, an hypothalamiologist may need to evacuate the accumulated blood. Chemical burns, exposure to irritating acids or alkaline chemicals can severely damage the eyes. So, corneal abrasion and ulcerations with subsequent cataracts formation may lead to permanent vision loss. The lens and the chambers of the eyes can also be affected. So, how are we going to treat all this shit? So, treatment, if any accidental substance come into the contact with the person's eye, wash that bitch out, meaning irrigate it with water for about 5 minutes. The minimum is five, it may be longer. During irrigation of the eye, direct the flow of water so the solution does not come in contact with other eye. After this initial irrigation, the person should immediately report to an emergency department or an ophthalmologist office for further treatment. There, there, the eye is lavished, is flushed out for an extended period. That's what lavish means, flushed out. This prolonged irrigation removes acids and alkalis that can continue to melt the eye, even after it seems that thorough irrigation has been performed. So you just got to keep flushing and flushing and flushing till all that shit come out. After irrigation is complete, a topical antibiotic ointment is instilled, and then continue follow up with the eye doctor. Keratoplasty, corneal grafting, which is discussed um in the next section. Okay, it may be done. Okay, so with the nursing alert, just know have extreme cautions for instilling any type of meds into the container um, of eye meds. Wait a minute. Extreme caution is necessary when instilling any type of medications into the container of eye meds or similar to bottles for other solutions. For example, some non-eye solutions, I come in. Why they say I two times? Let me go to that one. Let me find it. Okay, so the book say extreme caution is necessary when instilling any type of medication into the eye. Extreme caution is necessary when instilling any type of medication into the eye. That sounds like into the eye containers. Okay, like I wouldn't be mixing up my damn shit. Okay, in, into the eye containers of the medication are similar to bottles or other solutions. Okay. For example, some non-ice solutions, that's not supposed to be there, come in small bottles with droppers, like guac solutions used to test for occult blood. These solutions can be extremely caustic and can cause blindness. So I'm gonna read that whole thing again. My bad, y'all. Shit, please fuck up. So extreme caution is necessary when instilling any type of medication into the eye. Containers of the eye medications are similar to bottles for other solutions. For example, some non-eye solutions come into small bottles with droppers, like guac solution used to test for occult blood. Now, these solutions can be extremely caustic and can cause blindness. Now, with corneal abrasion, what that is, it's like it done been cut. It's like you know how you have an abrasion on your leg or your arm, you fell off your bike or some shit. So that's all it is, but it's on the eye. And it involves the outer layer of the cornea and are often caused by branches, fingernails, paper, and contact lens injuries. Symptoms include severe pain, redness, and tearing, meaning lacrimation. Anytime you see lacrimation, you know that's tearing. Corneal abrasions are easily diagnosed with fluorescent dye installation. Remember, we it was on the test about a guy injured his eye, a tree branch or something, and that was from fluorescent dye installation. So, following installation, the area is viewed with the cobalt blue light, and the abrasion appear green. Treatment treatment of corneal injuries include installation of antibiotic drops or ointments and pressure patching. These measures should result in healing within 24 to 48 hours. If healing does not occur properly, follow up is required to prevent complications. So you got 24 to 48 hours for that shit to heal. If it don't, follow up with the doctor. A serious complication is corneal destruction, which often requires corneal transplantation. That's bad. If severe visual impairment results from irreversible changes in the cornea, vision might be restored by corneal transplantation, which is keratoplasty. And keratoplasty involves the replacement of damaged corneal tissues with human donor tissue that is obtained within 6 hours after death. The tissue is rarely rejected because it has minimal blood supply. Now, with the detached retina is the separation of the retina from the choroid, thus depriving the image receiving layers of its blood supply. Separation of these layers usually follows a hole or tear in the retina, which may result from a blow or injury. Myopia, which is degenerative changes. Well, no. Separation of these layers usually follows a hole or tear in the retina, talking about detached retina, which may result from a blow or injury, myopia, degenerative changes, surgery, tumor, diabetic retinopathy, or extreme hypertension. Because of the sensory layers, they can no longer receive visual stimuli. I'm going to say that again. Because of the sensory layers, they can no longer receive visual stimuli. Vision in the affected area is going to be lost. Vision in the affected area will be lost. Symptoms and well, signs and symptoms may occur suddenly or gradually. If a large part of central retina is affected, vision loss is greater than if the outer layer, well, if the outer edges are destroyed. The person may see flashes of light, known as flashers, or moving spots, known as floaters. Vision may be blurry, or it may seem as though a shade has been pulled over part of the, the vision. Usually, no pain occurs with a detached retina. Treatment. One possible treatment for detached retina, oh, I'm talking about retina. Retina is surgical procedure called scleral. And called scleral buckling. So one possible treatment for detached retina is a surgical, okay, is a surgical procedure called scleral buckling. The operation shortens the scleral, thus allowing contact between the retina and the choroid. Procedures involving use of a layer beam like photocoagulation and the application of extreme cold, which is cryosurgery, or also used to create an inflammatory reaction and promote healing. So these are the treatments. This is what a detached retina look like. Got the fluid coming up in that thing. That's the lens. That's the vitreous humor on the inside. So the retina, it didn't toe up. Now the fluid coming all out. So this is retinal detachment. So the ear and hearing disorders. So what we need to know is the branch of medicine concerned with this the ear disease and disorders is called otology. The healthcare provider in this specialty is known as an otologist. The otologist tests hearing, examines the ear for signs of disease, and determine the treatment. So know about what an otologist does. Like we had to know about what all the eye doctors do. To know about the otologist. And then the otologist test, we already said that. The audiologist, this is the person that for hearing, audio, hearing, audio, audiologist, hearing by various means. This is the ear, nose, and throat doctor. This is the ear. This is the nose. This is the throat. So otorhinolaryngologist, otorhinolaryngologist, or otolaryngologist. Shit, I said that again. Oh, otorhinolaryngol or it's otorhinolaryngologist or otolaryngologist treats disorders of the ear, nose, and throat. EENT refers to ear, well, eye, ear, nose, and throat. Type of hearing loss, impaired hearing can occur at any age. Undetected hearing deficit can be misrepresented, misinterpreted as lack of interest, attention, and deficit disorder or mental retardation. Please don't make me cuss y'all ass out because I can't hear. That does not mean I fall in the mental retarded category. Get that shit off your mind, baby. Injuries can affect hearing and cause deafness, disease. Exposure to excessive noise or congenital factors may also impair hearing. Hearing loss may vary from slight to moderate or may be complete. Total deafness usually cannot be corrected, right? So a cochlear implant may be helpful to some deaf clients. Congenital deafness may result in the inability to speak or in speech that is very difficult to understand. Conductive hearing loss, let's talk about that. Congenital, that just means somebody was born that way. Cochlear implant, they can be helpful for to some deaf patients. They said it ain't helpful for my black ass. Total deafness, they ass can't hear, cannot be corrected. Okay? So conductive hearing loss. A conductive hearing loss is sometimes referred to as transmission hearing loss. Conductive hearing loss is referred to as transmission hearing loss, in which the conductive of sound waves to the organs of hearing is disrupted. Know that. It may be caused by a disorder in the auditory canal, the eardrum, or the ossicles. And the ossicles are the tiny bones of the middle ear. The ossicles are the tiny bones of the middle ear. I know that's the stapes. It's MIC, the meniscus. We'll probably come across it because she might ask, what are What are those the ossicles called? What are the tiniest bones? Because I heard her mention that. But even when you learn anatomy, you need to know what are the tiniest bones in the of the middle ear, which are the tiniest bones in the body. So it was three of them. It was M, I, and C. Incubus, meniscus, and stapes, I think. And I could be totally wrong about the M and the I. Hopefully we'll run across it. Fluid in the middle ear is most common cause. It's the most common cause. Okay. So conductive hearing losses are further classified as follows. Air conduction loss is caused by a defect in the external, meaning the outside auditory canal. And then with bone conduction loss is caused by a defect in the bones of the middle ear. So that's common sense. Air conduction loss is caused by a defect in the external auditory canal, and bone conduction loss is going to be a defect in the caused by a defect in the bones. That's the key word, bones of the middle ear. So sensorial or perceptive hearing loss, sensorial or perceptive hearing loss involves a disturbance of the organs of the inner ear or of transmitting nerve, right? So conductive losses. With conductive losses, otitis media, middle ear disease, perforated eardrums, otosclerosis, fixation of ossicles, defects of external auditory canal, obstructions of external auditory canal, which are foreign bodies or serum. That cerumen is wax. So these are conductive losses, the common causes. We have to know this box. We have to know it. So you need to know what is the types and common causes of hearing loss. It's going to be conductive losses or sensorial losses. Now with conductive, once again, otitis media, middle ear disease, perforated eardrum, meaning it's been bust. Otosclerosis, fixation of the ossicles, defects of external auditory canals, obstruction of external auditory canal like foreign bodies or wax, which is cerumen, sensory neural losses. That word right there, neural. That's going to have something to do with nerves. That's going to be nerve damage. So excessive noise causes sensory losses. Presbycusis, that's because your ass and got old, cause hearing losses. Autotoxic drugs, tumors like a neuroma, see, nerves, acoustic neuroma, Meniere's disease, congenital factors, trauma, skull fractures, brain damage, cause what? That cause nerve issues, nerve damage to the brain, or stroke. Viral infection like meningitis will fuck up and cause sensorineural losses. Notice, very important. A sensory hearing loss involves the organs of corti, which is scholia, or the auditory nerve, the eighth cranial nerve. Okay, the eighth cranial nerve. It involves the organ of corti, which is the cochlea, or the auditory nerve, which is the eighth cranial nerve. Sensory hearing loss is further tested to differentiate between the following types: sensory cochlear factors such as trauma, viral infection. We just read that toxic drugs or Meniere's disease can result in cochlear hearing loss. Like I told you, Tank has Meniere's disease, the singer Tank. These sensory conditions are usually not fatal. And then with the neural eighth cranial nerve defect, when you see that word neural, but they just put it together. So the eighth cranial nerve defect, a tumor of the cranial nerve called an acoustic neuroma can cause a sensory neural hearing disorder. These rumors are potentially fatal. I'm talking about rumors. Tumors are potentially fatal. Now, other causes of sensory Other causes of central hearing loss, excuse me, include excessive noise and congenital predisposition. Now, if that organ well, if the organs of hearing are impaired or deteriorating, the person has little chance of escaping deafness unless the cause of difficulty is discovered before damage occurs. Okay, moving on down. Um, Keep in mind that with the central hearing loss refers to the brain inability to interpret sounds after they have been transmitted. This sometimes occurs in atherosclerosis or after a stroke. I think we should know that. Central loss refers to the brain's inability to interpret sounds after they have been transmitted. And it occurs in atherosclerosis and a stroke. Functional hearing loss. Now, that was central. Functional hearing loss. In functional hearing loss, no organic cause is found and no damage to the auditory nerve is visible. So no organic cause is found, no damage to the auditory nerve is visible in functional hearing loss. Functional hearing loss is believed to stem from some underlying psychological problem. Professional counseling sometimes helps with functional because it's like they can hear, but and we tested and it's showing like I don't know what the fuck caused it. Like I don't see nothing wrong. I don't see no damage or nothing. So your ass might be set tripping around this bitch. So we need you to go see a damn counselor or something because you got some psychological problems going the fuck on. That's what that means. I want that to stay together. So let me make that a little smaller. If I make it a 9. Oh, gotta make it an 8. Bring it down. So let's talk about prevention of hearing loss. All individuals should be aware of the dangers of infections and noise in regard to their hearing. The nurse can provide preventative teaching. That's going to be down here. So with the preventative teaching, let's read that real fast and then scroll right the fuck back up. So this is in practice educating the client, 80-3, prevention of hearing problems. Avoid excessive noise like loud music, television, work environment. Keep volume down. Wear protective gear if working in noisy areas. Protect ear on cold and windy days. Be aware of dangers of riding in cars with windows open or in motorboats or motorcycles. I never knew that. Never knew that. I guess because something can probably bust you in your ear or something. Wear earplugs for swimming if ear problems are present. Dry ears thoroughly after bathing or swimming. Do not place foreign objects in your ears. Do not clean ears excessively. Do not pick or pull ears excessively. Do not put no damn Q-tip in your ears either. I know we've been doing that. Well, some of y'all been doing that all your life. Had to fight with that damn wax in your damn ear with them Q-tips, but you're not supposed to do that. Prevent and treat infections immediately. Ear infection is not to be treated personally. See a professional. The ear is in close proximity to the brain. You will fuck around and get meningitis. So if you got an ear infection, go to the doctor. Have ear piercing done by a healthcare provider or trained technician. Follow instructions for follow-up care. Never knew that. So stay the fuck out of Walmart. And what's the name of that store in them out? Claire's, I think. Stay up out of there letting them employees that's only been there for 2 weeks pierce your damn ears. Okay, don't know, baby, take your ass to the doctor. I never fucking knew that. Or it's a trained technician, so I guess they train, whatever. I'm going to the doctor if I wanted to ever get my ears pierced again. As symptoms of hearing loss, see a healthcare provider immediately. Let's scroll the fuck back up. So, prompt treatment of infectious, prompt treatment of infectious disease as upper respiratory infections that can spread to the ear helps to prevent hearing loss. Okay, when you promptly treat it, prompt treatment of infectious disease that's upper respiratory infection that can spread to the ear helps to prevent hearing loss. So treat that shit promptly. Use the use of antibiotics early in the course of an ear infection also helps to arrest the disease and to prevent later complications. Noise pollution is of great concern, particularly for young people and workers in industry. Um, Wearing protective care, it's supposed to be care, not car. Wearing protective care devices can prevent many hearing disorders. OSHA has established standards for industrial general. The loud volume generated for audio from audio equipment is often harmful to young people's hearing and can result in permanent hearing loss. That ain't where my shit come from. Y'all know I pull up banking, you know, that day I'm Lil Boosie or whatever. That ain't got shit to do with it because I can't hear that shit like that anyway. So shit I already fucked up. So, but for y'all who can hear, for y'all that can hear, fix your damn ears. I mean, protect your ears. You can't do what I do because my ass this been all my life. So don't be don't have them speakers blasting like that. Protect your damn ears. Okay. What the hell? Okay. Now my sister finna again block her for a couple of seconds because I'm trying to study. Okay, so disorders of the external ear. Most external ear disorders are more annoying than they are serious. That's all it is. They're fucking annoying. So, if proper treatment is given, the condition tends to heal without difficulty. Unfortunately, many people attempt to treat these disorders by themselves and other shit develop. Impact the earwax in the auditory, well, it's impact the earwax, cerumen, like I said, cerumen and what is wax. And the auditory canal is one example of a minor condition that requires medical attention. Wax can be removed by irrigating the outer ear with a solution warm to temperature of 98.6 degrees, that's body temperature, or 37 degrees Celsius. Instruct the client not to attempt to remove wax or other objects from the ear. Pushing or on a foreign object may age the eardrum. Hold on, let me make sure that's right. Just know, let me look that up real fast and make sure I put the right word in there. But don't put no goddamn hairpin in your damn ear. Yep, that's right. It may age the eardrum. Do not, you say pushing a foreign object trying to get that wax out. Don't do that. Don't put no fucking hairpin in your damn ear. If the client has a perforated eardrum, keep the fucking water out. Irrigation might force the wax and the solution into the middle ear and cause an infection. So no irrigation, none of that, because their eardrum is bust. That's basically what that means. It's punctured, so you're not going to do irrigation because it may fuck around and cause an infection. Poking at the wax with the finger, baby. What I just told y'all is a hairpin or an applicator may injure the canal and cause infection. Additionally, the wax can be pushed in further. Never use a hairpin. Never use that is not what the fuck Q-tips are for to dig in your ears. I don't know who said that shit, but that ain't what it's for. You're not supposed to use Q-tips in your ears. Now, okay, you want to be like me so bad? Put that shit in your ear and see what happens. You're gonna be around here talking about, huh? What? Just like with me. Furuncles, furuncles. I'm talking about furuncles. Furuncles. These are boils or infections of hair follicles. Furuncles or infections of hair follicles, that, aka boils. All right, which drain pus material, which is purulent. A furuncle extends through the dermis into the subcute tissue and can form small abscesses in the auditory canal. Ear furuncles commonly result from irritation due to scratching within the car. Within the car? Oh, shit. Woman. Ear fungus commonly resulting from those juicy scratching within the ear. Damn, my bad. Such as using a cotton tip applicator to remove wax. Hmm. Just told your ass that. Don't use that shit. So, ear furuncles commonly result from irritation due to scratching within the ear, such as using a motherfucking Q-tip applicator to remove wax, and you fuck around and get a ball because some of that cotton be left in the ear. Due to the location in the ear, these boils can be intensely painful. Symptoms may cause itching. Gonna have some itching going on, irritation, and occasionally causing a temporary hearing loss if infection is prevalent. If the furuncle bursts, discharge will drain from the ear and pain improves immediately. Well, that's a good thing. So heat may be applied and antibiotics are sometimes given. For foreign object, you got them badass kids or dumbass people who are emotionally, oh, I'm sorry. You got children or persons who are emotionally or cognitively challenged, not dumb, I'm sorry, may put objects into the ear. A healthcare provider must remove any objects. Pushing on the objects may cause it to travel further into the canal or cause the eardrums to rupture. If the foreign object is a food substance such as a pea bean or piece of corn, moisture will cause swelling and extreme motherfucking pain, often leading to damaging of the eardrum. Sometimes insects bring their bitch ass up into the auditory canal. If they remain, they can cause some extreme distress by their filtering and buzzing. I saw that shit one time on one of these medical shows, and this man came into the ER and he could not stop screaming. It's like he was in shock. He was laying down in the bed, he couldn't move, and his eyes were wide open. And his wife was like, I don't know what the hell going on with him. And he was just talking about, oh, oh. That's all he kept saying. And it was like he was in shock. So they was like, what the fuck happened? Guess what they pulled out that nigga ear? I'm sorry, guess what they pulled out that man ear? A damn roach. They pulled a roach out his fucking ear. Oh, that shit was just crazy to me. So just know them insects will fuck you up and cause some extreme distress. If a flashlight is held to the ear, that bitch, that roach or that ant or that spider, he'll crawl his bitch ass on up out of there. Sometimes a few drops of mineral oils, alcohol, or anesthetic jelly will anesthetize or kill the causing or kill the causing it to or kill the. It's supposed to be insect. Kill the damn roach, causing it to float out of the client's head is turned to the affected side. Hold on. Sometimes a few drops of mineral oils, alcohols, or anesthetic jellies will anesthetize or kill the damn insect with a damn roach, causing it to float out of the client's head if turned to the affected side. So if none of these measures work, the client, you got to go see the fucking healthcare provider ASAP. Trying to remove an insect with tweezers, y'all see that? It's dangerous. Put some fucking tweezers in your fucking ears and see what happens. Removing an insect from the ear is a delicate process that requires great skills. If you know you got a roach in your ear, just go to the damn doctor. That's what I'll do. But like they said, it's been different shit you can do. So we may have to know that put some mineral oil in that bitch, alcohol, anesthetic jellies. They may, get the damn bug out of there. Don't put no tweezers in there, no Q-tips, no shit like that, no hairpins. If don't none of that shit work, get the doctor. Let's talk about, I think this is swimmer's ear. Yeah, this is the swimmer's ear. Otitis external. Ms. Johnson told me I didn't know what I was talking about when I said the swimmer's ear. I know what I'm talking about, Ms. Johnson. So otitis external, external otitis, inflammation of external ear is most commonly caused by chronic external ear inflammation. Prolonged exposure to water is the cause, and therefore it sometimes causes swimmer's ear because a lot of swimmers get this. A lot of people that swim, Like those Olympic people, you're gonna see them plugging their ears up because they're always in water, they're always training, and that's why it's called. This is called the swimmer's ear. People that's always in water. So the client receives antibiotics and is advised to avoid swimming until the infection clears. The client should then wear earplugs when swimming. Applications of ear drops composed of substances such as you see all this stuff can be used for prevention. But I did see that on one of the she might ask us about that one. The boric acid ear dry swim ear. So fungal infection. Fungal infection in the auditory canal tends to occur in warm, deep climates, especially when the auditory canal has not been completely dried. Most of these fungi are opportunistic and feed on serum or dead skin cells. Eardrops containing antifungal meds, alcohol, and glycerin can treat such infections, which may resist treatment. After treatment must continue for a number of weeks, okay? So that's with fungal infection. Fungal infection in the auditory canal tends to occur in warm, damp climates, especially when the auditory canal has not been completely dried. Most of these fungi are opportunistic and feed on serum when or they feed on the wax or they feed on dead skin cells. Eardrops containing antifungal medication, alcohol, and glycerin can uh, treat such infections, which may resist treatment. After treatment must continue for a number of weeks. Punctured, punctured tympanic membrane, a punctured or perforated tympanic membrane that's just your eardrum and buzz is a serious threat to hearing later in life, as well as a possible source of middle ear infection. This is what happened to Halle Berry when she was dating Wesley Snipes. Like, this is real life facts. He punched her in her damn ear because I don't know if y'all know that they used to date. And Wesley Snipes is a black. He has a black belt. He's a martial artist, and they got into it. He hit her so goddamn hard in her ear, bust her damn eardrum, and Halle Berry is deaf in her left ear. So she has a puncture or perforated tympanic membrane. She cannot hear out of her left ear. So although the perforated will often heal spontaneously, surgery is sometimes necessary. Occasionally, a rig a maricto a maryngotomy, a maryngotomy. This is surgical incision into the eardrum and drainage is done for therapeutic reasons. Now, when we talk about piercing earlobes, like I said, healthcare provider or a damn trained technician, this is cosmetic procedure. I'm gonna go to the healthcare provider since they do it. I did not know they do it. Like if I had to get mine or get one of my adopted babies in the future, get their damn ears pierced. Um, that's what the fuck we gonna do. We gonna do that. I'm gonna go to the doctor, not to Walmart, no damn more, cause they had my ears uh piercing holes crooked than a motherfucker anyway. I had to take them holes out. So client teaching is important. Oh, okay, this is sterile technique too, y'all. It's a sterile technique. Teach important. After ears are pierced, client is advised to keep the original earrings in for at least 2 weeks. We might have to know that. Don't try to go home and put them goddamn black blood diamonds in your ears after you just got your damn ears pierced. Keep that shit in your whatever the doctor or the trained technician put in your ear. Keep it in there for at least 2 weeks and cleanse the earlobes, often with an aseptic solution such as alcohol. It's all y'all know how it is. Y'all done had plenty of piercings. We talked about this shit last week. Y'all had talking about nipples piercings and booty hole piercings. Y'all know what the hell to do with those piercings. So, the practice of piercing, the external care above the lobes is often more common, but not as likely to cause infection because the earlobes are thicker and not as quick to heal. Okay, disorders of the disorders of the middle ear. Now, with disorders of the middle ear, there's otitis media. Otitis media is the inflammation of the middle ear. The ear is especially susceptible to upper respiratory infections, which can travel through the eustachian tube from the nose and the throat. So children are especially vulnerable to these infections because their auditory tubes are straighter and shorter than those of an adult. The four different types of otitis media: acute, serious, chronic, chronic, supportive, chronic. Hold on, that look like that's more than one, two, three, four, five. That's more than four. Hold on. One, two, three, four. So serious. Hmm, what's all that at the top? Yeah, but whatever. It's in the book like that. The four different types of otitis media or acute, serious, chronic, support, supportive, chronic, serious, and chronic supportive. Did I put that shit too? Oh, that's what it is. Nah, let me make sure. Let me look at. Hold on. Serious is acute, serious. And then you got chronic, supportive. Then you got chronic, serious. Okay, and chronic supportive. Okay, okay, okay. So, serious otitis media results from what? It's going to result from fluid that collects in the middle ear, causing an obstruction of the auditory tube. This condition may stem from infection, allergy, tumors, or setting changes in altitudes. Symptoms are going to include crackling sensation and fullness in the ear with some hearing loss. If this condition is not treated promptly, guess what? Fluid pressure may rupture the damn ear, well, rupture the eardrum. The treatment of choice remains controversial. Okay, so it didn't matter what I did with this one because, yeah, all the shit gonna be okay. So let's talk about this. It consists of antibiotics. It consists of antibiotics use or laryngectomy. This is followed by analysis and treatment of the original cause of the difficulty, such as removal of a tumor and the nasopharynx. Supportive form is generally caused by an upper respiratory infection spreading through the auditory tube. Pus forms and, hold on, let me slow the fuck down. We're talking about, I think we're still talking about series otitis, okay? Like I said, it consists of antibiotic use or laryngectomy. This is followed by analysis and treatment of the original cause of the difficulty, such as removal of a tumor in the nasopharynx. Supportive form is generally, and we're moving on. So supportive form is generally caused by upper respiratory infection spreading through the auditory tube. Pus forms and collects in the middle ear in the supportive form to create pressure on the eardrum. Symptoms are going to include fever, earache, and impaired hearing. The eardrum is going to be inflamed and and bulging may rupture. No, hold on, y'all. This is supportive form. And bulging, that's what the book say. The eardrum is inflamed and bulging and may rupture. Okay. Initial treatment is often antibiotics. Now, also myringotomy may also be indicated to prevent rupture of the eardrum. If spontaneous rupture of the eardrum occurs, foreign, which disrupts normal ossicle vibration, can result. Often this permanently impairs hearing. Now, with chronic otitis media, how this can develop, this is another one. How this is disorder. So how this can develop is if acute purulent otitis media is not treated promptly, that's how it come about. So in the past, mastoiditis, encephalitis, and meningitis were also complications. However, today these complications are rare because of the use of antibiotics. Other problems include nausea, vomiting, dizziness, injury to the facial nerve, causing facial paralysis or a brain abscess, all of which may start with a simple motherfucking earache. Hmm, hmm, hmm. Fortunately, these serious complications are less frequent owing to improved treatments for acute infection. Chronic serious otitis media is usually associated with a punctured eardrum or may be complications of acute otitis media, mastoiditis, or a severe upper respiratory infection. Now, that's chronic serious otitis media. Okay, that's the other disorder. Don't get them two mixed up. Chronic otitis media. So pause or stop, look at that, read it over, and come up with ways to try to remember it. Symptoms include ringing in the ear, hearing loss, pain, purulent drainage. Antibiotics are going to be prescribed, and mastoidectomy may be necessary in some instances. So, steroids may be given to reduce the inflammation, of course. You got treatment. Laryngectomy is the common procedure used to treat otitis media. It releases pressure and relieves pain. Healing proceeds rapidly. Discharge from the ear is bloody at first, then purulent. To avoid interfering with drainage, do not plug that motherfucking ear with no cotton ball. Place a small piece of cotton in the outer portion to absorb the drainage and change it frequently. Give order antibiotic. Rest adequate diet and prevention against chilling are recommended. The PE, which is polyethylene tubes, are often inserted through the eardrum incision into the middle ear. This procedure is commonly done in children with recurrent ear infection. PE tubes allows continuous drainage for the middle ear. In this case, the client must use cautions to prevent water from entering the ear. Swimming and showering, don't fucking do it. Tempo Tympanoplasty is the plastic reconstruction of the tiny ossicles of the middle ear. It is done when infection or tumor has destroyed or fused these bones together. The the bone reconstructed involves the structures from the oval windows to the tympanic membrane. Tympanoplasty is a delicate procedure performed with the aid of an operating microscope. So tympanoplasty is going to try to help you with the world's smallest bones in your body. These are the smallest bones in your body. So the goal of surgery is to preserve and to maximize hearing. So autosclerosis is a bony fixation of the stapes, which is one of the small, no, not one of, I mean, you got three of the smallest bones in the body, but the stapes is the smallest bones in the body. One of the three ossicles in the middle ear that transmit sounds to the inner ear. This condition slows or stops the vibration of the stapes and impairs or destroys hearing. Autosclerosis usually develops slowly. It appears to have a hereditary basis because a familial tendency is found in its development, right? So it is the most common cause of conductive deafness. Most common cause of conductive deafness is due to the autosclerosis. Um, Signs and symptoms. One of the first signs of autosclerosis, ringing in the ears. That is what the fuck I have. Baby, that's what I got all day, every day. My shit ringing. Ringing in the ears, which is accentuated in quiet surroundings. That should be loud as fuck. It may occur for some time before the client notices a hearing loss. The client may not notice that he or she is losing the ability to hear until ordinary conversations become difficult to hear, especially when others speak in low tones or there's background noise. Like, yeah, I can't hear whispers at all. So you whisper in my ear all day, and I be like, oh, okay, I can't hear that shit. And then background noise when the whole class is talking, then one motherfucker trying to talk to me, I can't hear y'all ass. I can't hear y'all. So surgery or the use of a hearing aid may help the client with this condition. Treatment: surgery to restore vibration of the stapes. Stapes mobilization may not be effective. Okay, stapes mobilization. So surgery to restore vibration of stapes may not be effective. Cause like ear, like when it's damage to this type of stuff, it's like it's permanent. Like ear damage is permanent. Ain't no really fixing the shit. So therefore, usually the client must make a decision about whether to have surgery. That's when they think about getting a cochlear implant and shit like that to try to help them hear. The operation is done under local anesthesia with an operating microscope and freeze the stapes so it can vibrate. And a more common procedure today is the removal of the stapes, which is called stapedectomy, and replacement with the prosthesis. Well, shit, I'm gonna have to see if I can get that. They ain't say nothing about that. Okay, so many clients are able to hear immediately after prosthesis placement. I probably don't want it. I probably don't want it. However, the return of hearing is not necessarily permanent. Deafness may recur suddenly. Such deafness is owing to an infection or to formation of scar tissue. If stapedectomy is unsuccessful, fenestration, which is creation of a new oval window in the ear, may be done. I ain't finna let them do all that shit to me. Fuck all that. Disorders of the inner ear. Inflammation of the inner ear is called otitis interna or labyrinthitis. Labyrinthitis. That's the inflammation of the inner ear. You see that internal right there, otitis interna. Almost every disorder of the inner ear is difficult to treat, right? Because it's the fucking inside of the ear. Neither surgeon nor hearing aids can help that bitch. Um, Neither hearing aids can help inner ear deafness, which is perceptive deafness. Drugs used to treat conditions unrelated to the ear can harm the inner ear, like ototoxic, and may cause an inner ear disorder. Streptomycins, for instance, may injure the auditory nerves. So streptomycins, we know those are used for they're like for strep throat, and it's an antibiotic for strep. Will fuck up the inner ear. Some diseases of the aging process may also cause inner ear damage. Treatment often consists of preventing further injury and training in lip reading because you pretty much finna lose your fucking ear, your hearing altogether when you get deep up in that damn ear. This is what Tank has, the singer Tank, Meniere's disease. Meniere's disease is a disturbance of the inner ear semicircular canals, which are responsible for maintaining a sense of stability and equilibrium, which is balance, due to fluid distension of the labyrinth leading to destruction of the cochlear hairs. I told y'all there are hair cells that when the noise hit the hair cells, they vibrate and they do their little thing and go on into your ear with the smallest bones in the ear to try to help you hear the sound. So one theory suggests that the herpes simplex virus is causative agent, but no specific cause is universally identified with Meniere disease. So signs and symptoms are devastating and alarming. The affected individuals had sudden attack of severe and true vertigo, a sensation of spinning. That's what he said. He said he couldn't hear shit and he was spinning around. He said everything was spinning, either of oneself or of one's surrounding. Vertigo is not the same as simple dizziness, although sometimes the terms are used interchangeably. Vertigo is not no, it's just not no regular damn dizziness. Like vertigo, baby, that shit, oh, that shit is horrible. From the stories I've heard, thank God ain't hit me with that shit. But the stories I heard that shit bad. So nausea, vomiting, and tinnitus is, it happens with the Meniere disease. Clients are maybe unable to walk, of course, because you fucking spinning around. Migraine headaches may accompany the disorders. The person definitely should not drive. If the condition is untreated, hearing eventually deteriorates. Bed rest during an acute attack is sometimes necessary. Sudden attack of Meniere syndrome can be fucking violent. They may last for only a few minutes or several fucking weeks. Whoa, wait, I couldn't do that shit. During which time the quantity of fluid in the space between the semicircular canal increases. During remission, declines hearing and balance are often normal. So, key concept to remember: the person with Meniere disease is often frightened like a motherfucker. I can imagine. Vertigo can occur at any time without warning. It just, that bitch just hit your ass. It just hits you. That's it. So, treatment, medical treatment aims at relieving the symptoms to decrease edema and pressure on the inner ear, which can cause vertigo and nausea. Antihistamines, anticholinergic, corticosteroids, and mild diuretics may be used. Antiviral drugs such as acyclovir may help diminish the duration of disease but will not reverse existing damage. The person may receive sedatives or tranquilizers to subdue apprehension and accompanying anxiety. I can imagine they are full of fucking anxiety just because you can't stop fucking spinning, and especially if it's lasting for weeks. So vertigo may be treated by a device that provides trans tympanic micropressure pulses, which they know as Menead. Sometimes, when only one ear is affected, an operation to cut the auditory nerve is performed. This results in complete deafness in the affected ear. Wait, dang. The client is advised to stop alcohol, no fucking caffeine, no tea, no Coca Cola, no chocolate, no tobacco from the diet. So it sounds like no nicotine and no caffeine. A low sodium diet may be suggested, although the benefits of the diet remains controversial. And then, oh Lord, thank you God, this last page. So nursing considerations when caring for a client with Meniere disease: avoid jaw ringing the bed. Okay. Oh Lord, damn, my bad. Avoid. Don't bump into the damn bed. Okay. Make don't make any sudden movements. Turn on bright lights. Make loud noise. Don't do that. Don't bring your big mouth ass up in there. Somebody got fucking Meniere disease. Rationale: these actions may precipitate an attack. Do everything slowly and explain actions to the client ahead of time. Protect the client from falls. Rationale: if vertigo is severe, the client is in danger of falling. Keep the bed in the lowest position to protect against dangerous falls. You want to give fluids and foods in small amounts. The rationale is the nauseated client is better able to tolerate small amounts. Remember, the attacks are so fucking devastating that the client is understandably apprehensive. And we should reassure the client that relief is possible. Okay. Let them know this shit ain't gonna last always. I know it's fucked up, but it's not gonna be here always, Mr. James. So, disorders of other special senses. In addition to hearing the vision, well, to my hearing division. In addition to hearing and vision, the special senses include senses of touch, taste, and smell, tactile disorders. That's going to be the touch, right? The ability to feel softness, pressure, pain, heat, cold. This sense also assists in proprioception and helps the inner ear to maintain balance. The body's muscle and tendons give information to the ear's labyrinth, which is involved in maintenance of balance. A tactile sense disorder often results from a neurologic disorder. Persons with spinal cord injuries, nerve transmission deficits, or disorders in the brain sensory may be unable to feel or interpret pain. So these are the people that are unable to feel or interpret pain, or the people who have spinal cord injuries, nerve transmission deficits, disorders in the brain sensory areas. Okay. We all know about peripheral neuropathy with those diabetic patients. They have a subsequent loss of sensation, especially in the extremities, the fingers, the toes, and the lower extremities, the upper extremities. Clients with tactile difficulties, they may be in danger because they can't feel whether something is hot or something is cold, and they don't have that impulse that goes to the brain and say, "Your motherfucking ass on fire," or "You freezing." You know what I'm saying? So that can be very, very dangerous. In some cases of chronic pain, nerve transmissions may be intentionally interrupted by surgery. In other cases, the person is unable to maintain balance and may easily fall or may be dizzy much of the time. Gustore, gusta. I just know that's just a tongue when I see that damn gusta. It just makes my mouth watery when I say that gusta. Gustore, gustatory, gustatory, sense of gustation. Think of quenching your thirst is boosting. Hell, I don't know. So the sense of taste, right, involves the sensation of sweet, salty, sour, bitter, and and others. Disorder in the sense are usually not life threatening, but like an absence of the alteration in the sense of taste may reduce the person's interest in eating, though. So the loss of sense of taste is commonly associated with the loss of smell. Y'all know when people say, "Oh, did y'all smell her? That shit got up in my mouth." It goes hand in hand or whatever. So olfactory disorders. That's your damn nose, okay? Olfactory, sense of olfacation, sense of smell. Um, the Lord blessed me with a great olfactory sense. Baby, y'all know it. Baby, this nose don't play no damn games, okay? Greatly affects the sense of taste. Disorder in olfaction are usually not life threatening, but they may reduce pleasurable sensations in eating or in smelling flowers or perfume. In certain cases, such as gas leaks, that shit can be dangerous because if your nose ain't working and you got a fucking gas leak, you don't know, oh, I need to get the fuck out the house before I don't wake up, before I go on to glory. So baby, that's it. That's all. Y'all study this shit. I don't know if I had to add something. If I did have, yeah, I had to add one fucking box. I think, yeah, I had to add the box educating the client. On page 1404, that box will be added. It's not in this PowerPoint, but I did read it. Y'all should have read along with me when I told y'all to go to 1404. It's called In Practice Educating the Client 80-1 After Eye Surgery. We have to know that, they always pull things out of those boxes. Y'all got any questions, concerns? Don't call me. Bye.